Good afternoon, everybody. I am myself Dr. Chandramohan, MD of Preeti Urology and Kidney Hospital, Hyderabad, southern part of India. Warm welcome all of you who are watching this program. We have today 10 speakers, esteemed speakers from all over the world who will speak on A to Z RIRS in the area of their interest. As you all know, retrograde intrarenal surgery is more commonly used nowadays for the renal stone management. We have so many webinars conducted. We thought today some of the interesting topics are also added, some like infants RIRS, some like intrarenal pressure, some like complex cases by senior faculty. Now also on disposable scopes like that. All of you might have received the details of the today presentation. It will be around 1 hour 40 minutes and we will spare 20 minutes for the question answer. Before I go to the first speaker, I have to introduce Dr. Anil, who is co-host with me. He is from Bir Hospital, Nepal. He is very active urologist in Nepal with great interest in RIRS, who has even in India performed live surgeries with us. You might be knowing his face, and Anil will also present today, and at the same time he will host the session. Now this is the brochure which we have, and these are the Tanuj Paul Bhatia, Professor Lee Jun from Beijing. I will introduce detail when they are starting the case. Dr. Maishali Talso, Italy, who is also did fellowship from Oliver Traxer. Dr. Anil Shrestha, I already told, which is our co-host today. Dr. Siddhalinga Swami, who is our consultant at Preeti. Dr. Esteban Imilani, again, fellow from Nadiad, as well as Oliver Traxer from Spain. And Dr. Chandramohan, myself. Dr. Kandar Parikh, no need to introduce to Indians. Outside Indians, he is from Ahmedabad, one of the pioneers and one of the early persons to start RIRS in India. Iloren Tanidir from Turkey, who is very active in Turkey's country where RIRS is practiced very commonly. He is a well-known member there. Dr. Manas Babu, who is our consultant at Preeti Hospital. With this, Dr. Vijay Goli will add a later time from USA, who is a urologist practicing RIRS. With this introduction, I will close my screen, and now I will request first speaker Tanuj Paul Bhatia. I will introduce Tanuj Paul Bhatia is head of the department and senior consultant, Institute of Laser Urology Surgery, Sarvodaya Hospital. To be honest, more than this, he is the founder of Alto along with Nitish Jain, Aditya Sharma, and other people. Advanced endourology surgery, his area of interest are RIRS and the HOLEP. All the endourology he does very well. In fact, he is the mentor for holmium laser enucleation. He had various international presentations and national also. He is invited faculty in international and national also. His video got best prize in our national conference in 2007 on lasers. With this introduction, I am stopping sharing my screen. Over to Tanuj Paul Bhatia. You can unmute yourself.
Yeah. Thank you, sir, for the kind introduction, and thank you for this opportunity. Can you see my slides?
Yeah, we can see that.
So, good afternoon, everyone. A very warm welcome. I'll be talking about scopes and accessories in RIRS, and without wasting any further time, I'll move ahead with the presentation. So, talking about the types of flexible scopes, basically there are fiber optic scopes, digital reusable scopes, and digital disposable scopes. And if you look at the anatomy of a flexible ureteroscope, this is the handle of the scope, this is the working shaft, and this is the deflecting tip. And on the tip, there is a working channel inlet, the objective lens, and the fiber optic illumination. A fiber optic scope is basically made up of multiple fiber optic bundles which have internal reflection. That is how they transmit the image and the light the other way around. Yes, sir.
Did you optimize? It is little breaking. If you don't,
I did optimize.
You close the screen and restart once, please.
Okay.
Optimize again. It is little breaking in both the. How about others?
It's not very clear. It's like
Okay.
Okay, I'll just optimize it
Please
again.
start. No problem.
How is it now?
Yeah, it's
Still the
breaking.
same. Still the same. I think here also I'm getting the same vision
Then,
what you were getting with
so-
my video probably.
So what I will do is I will not optimize this time. Let me just. I have a very good connection. It should not be a problem.
No problem.
Yeah.
Meanwhile, the viewers are joining. It is around
Yes.
200 now. Let them join also.
How is it now, sir?
Yeah, it's not shared yet. It is okay, clear now.
It is clear. So probably by optimization my thing was okay.
This is wait. It is not shared. The screen it's not shared.
the screen has shared, but PowerPoint is not there.
PowerPoint
Okay.
is not there.
Okay.
I will do it again.
Yeah.
No, I think I get what the problem
2
is. Just 1 more minute, please.
For all the viewers, we have started just now. First speaker is Dr. Tanuj Paul Bhatia. As you all, there are nearly 200 people. This is a basic introduction slides. So you have not missed anything. We are starting in another a minute or so. Just checking the technical aspect of the clarity.
Just give me 1 second, sir. Actually,
No problem.
there
No
was
problem.
an issue with the PowerPoint. Actually,
These are all common.
Okay.
If anybody wants to know in advance any doubts, please, because in one day we cannot cover everything. Because it is A to Z, you can ask a number of questions. We will select. Fantastic. Now you can go ahead, Tanuj.
Yes, sir. So I'll start from where I left. So this is a dissected fiber optic ureteroscope, and we can see that this plastic tubing is the instrument channel. This is the light bundle, and this is the image guide, which are basically made up of fiber optic bundles. So coming to commonly used fiber optic scopes, I will be discussing only the most commonly used ones. We know that the most commonly used fiber optic scopes are P7 from Olympus and FlexX 2S from Karl Storz. So talking about P7, the main difference between P7 and the earlier P6 is that there is a graded degree of stiffness. While the proximal part of the scope is very stiff, the distal part is pretty soft, especially at this point. This gives us very good maneuverability in the system, and it has a 4.9 French tip, which is bullet shaped, which helps us to enter the ureteric orifice and into the ureter. And it has a 7.95 French shaft with high transmission characteristics, and it has a excellent Moir filter with excellent image. So if we talk about technical details, as I mentioned, the diameter of the scope is 7.95 French, the tip being thinner, and it's a forward viewing scope with field of view of 90 degrees, the length of 670 millimeters, and an inner channel diameter of 3.6 French. This is standard in every scope. Almost every scope, the diameter of the instrument channel is 3.6 French. So this is the image quality we get with the P7. As you can see, it's excellent image quality. We can clearly see the stone, we can clearly see the fiber, and we can even see the dust that is floating around. And there's no Moir effect there. So coming to the next most commonly used scope is Karl Storz FlexX 2S. It's a very nice sturdy scope with good vision. The main difference between the FlexX 2S and the earlier FlexX 2 is that it now has double fiber capacity. This gives us very good vision, because with the FlexX 2 there was an issue with the vision because of the screen door effect. And it also has a ceramic tip which prevents the tip against injury from laser fiber when we are using it. And it gives a 1:1 torque transmission. Talking about the technical details, this also is a forward viewing scope with the 270-degree deflection on either side. The angle of view is 88 degrees. The working length is 67 centimeters, and the working channel is 3.6 French. And the sheath size is 7.5 French, and this is uniform compared to a P7 where it is tapering. So this is the image that we get with the FlexX 2S. We can see that it is very clear and we are not seeing any screen door effect. Of course, we have to slightly defocus in both these scopes to get a good image. So this is just a chart comparing the two, and as I mentioned, the main difference is that there is a taper in the diameter in P6 and P7, whereas in Karl Storz there is a uniform diameter. It is on your personal preference which type of scope you would like. So, but as we know that poor visibility still remained the issue with fiber optic scopes. So newer chip-on-tip systems evolved. Karl Storz coming with the CMOS system and Olympus coming with CCD chip-on-tip. The advantage was of larger endoscopic field with improved resolution, but the larger tip by comparison to conventional one, this added to the size of the scope. So they are generally thicker than the fiber optic scopes. This is how the digital scope unit is. There is a chip on the tip. There is no camera head to be attached there. The image is processed in this processor and passed on to the monitor. And here we can see the difference between the fiber optic and the digital scope image. Talking about the commonly used digital scopes, Olympus V3 is the latest one from Olympus. This also has a Durobend insertion tube. So basically it gives that graded stiffness just like the P7. It has a knob that I will show in the next slide that with which you can actually rotate the shaft, and it has a 8.4 French diameter. We can see here the difference between the vision of a P7 and a V3, that is the digital scope. This is crystal clear. These are the technical details. It is a forward viewing scope with 80-degree field of view, and it has a diameter of 8.5 French, and this is almost uniform. A working length of 67 centimeters and an inner channel of 3.6 French, and the angulation is 275 degrees up and down. This is the knob I'm talking about with which you can actually rotate this scope. This is the image quality you get with the V3. So Karl Storz Flex XC, I believe, is the most preferred digital scope, and for me personally, this is a standard that I view any digital scope against. You know, when I have to compare the image and the maneuverability. Karl Storz Flex XC has a 8.5 French tape diameter with a ceramic liner of working channel. Again, this prevents damage while we are using the laser fiber very close to the scope. It has a CMOS chip on tape with a 1:1 torque transmission. Talking about technical details, the angle of view is slightly more than V3. It is 90-degree. Working length is of 70 centimeters. Working channel inner diameter is 3.6 French, and the sheath size is 8.4 French. So this is the image quality we get with the Karl Storz Flex XC. We can see excellent maneuverability. As you can see here, I'm actually fragmenting in the lower pole with the scope bent, and you can see excellent vision quality there. So this is a table comparing the commonly used digital reusable scopes. We spoke about Flex XC and V2, which are the most commonly used. Cost is pretty much similar. There is another one from Wolf, which comes by the name of Cobra, with the added advantage that there are two channels, but see what it does. The shaft diameter increases to 9.9 French. So you can use this exclusively with a 12 French access sheath only. So, but there were issues with reusable flexible ureteroscopes, like there's an issue of durability. The scopes don't last as long as we want them to. That there are costly repairs, and there is a sterilization and reprocessing protocols which are involved. Coming to advantages of disposable flexible ureteroscopes, which are new entries in the market, there is no risk of cross contamination. They are lighter in weight. There is no need of sterilization. It allows more torque without fear of breakage, and it eliminates the cost of repair. But does this actually translate to actual cost benefit? We will have a look at it later. So coming to commonly used disposable digital scopes, one of the most popular one is from Poussin, the U scope. These are the technical details of the Poussin scope. It has a 90-degree field of view, a forward viewing scope. The illumination is by optical fiber. You can deflect it 270-degree up and down on either side. And the diameter of this scope is 9.5 French. That is the diameter of the shaft. And the tip diameter is 9 French with a working length of 65 centimeters and a working channel of 3.6 French. Just to show you the image quality of the Pusen scope, definitely these scopes are very light and very user friendly, and they come with a monitor in which we can see the image. We can generally not attach them to our usual monitors, and you can see the excellent image quality that we have with the Pusen scope there. Good illumination, good quality, good maneuverability, but a wider scope. So this next commonly used scope is Boston Scientific LithoView. This is actually probably the most used and the most studied disposable flexible ureteroscope. So this has the advantage of a tip diameter which is slightly thinner, that is 7.7 French, but the shaft is as thick as Pusen, that is 9.5 French. It has a digital CMOS tip, and it comes with a touch screen which is very user friendly, and you can deflect it on either side 270 degrees. This is the image quality we get with a LithoView. It is nice and clear, but these black things on the corner, sometimes they tend to distract you. And one of the problem with some of these digital scopes is that, you know, a farther end you may not be seeing very clearly. Only whatever is close to the scope you see it clearly. Like you can see this calyx, it is dark here. So moving ahead, uh, I will be talking about some of the reusable digital scopes which are now available in the market. But these are reusable digital disposable scopes. They cannot be repaired and they have some limited life. The Pusen and the LithoView can be used for 4 hours. That is, there's a timer in the scope. So it's not just, you know, it's not really single use. You can actually use it for 4 hours. But these reusable ones that are available now can be used for as long as 18 to 21 hours. So one scope I am pretty much excited about is the endovasive endoscope. It comes with a dual light source. You can see here in the tip that there are two illuminating bundles. It has a 9 French outer diameter. It has a 3.3 French working channel. It has a CMOS image and an integrated camera head. And this is the processor. So basically, you don't need a separate screen for this. You can use the processor and you can attach it to your usual monitor in the OT. And this is the image quality we get with this endoscope. I'll just forward it a bit. So you can see, as I said, I always try to compare the image of digital scopes with Flex XC. And this is one scope I feel is pretty much close to the image quality of Flex XC. And the maneuverability is also very good, and it is a very light scope. And this one you can actually use for 21 hours. Although we are not sure whether it will actually last that long, but that's what the company says. So V-scope is another disposable digital scope, which is being very commonly used on trial in the West. And I have seen a lot of posts on Twitter and other social media regarding this, and surgeons are pretty much excited. So the biggest advantage is the thinner diameter of 8.4 French with a 275-degree dual deflection. It has a bullet-like tip, just like our P7, which helps us in going inside the ureteric orifice and into the ureter easily. There is no separate monitor required for this also, and it has excellent vision. This clip is actually from YouTube, but I just want to play it to show you the image quality of V-scope. Yeah. So you can appreciate, you can see how nice the vision is with this scope also. I'm not sure if this is available in India and the subcontinent as of now. So moving ahead. This is another scope available in India, especially it's actually a Chinese scope from a company called Shihin, but it is being marketed by UMD, who are marketing Quanta Laser in India. This is also a reusable disposable scope with a field of view of 120 degree with a forward viewing and 8.5 French outer diameter. So it is also relatively thinner. And just to show you the image quality, can you see here, this is a very nice image quality with this scope as well. This case is actually being operated by Dr. Nanjappa in Mumbai. and it has excellent image quality. And we are using, we can use our usual monitors with these scopes. Of course, there is a small monitor that they give, but we can attach our usual monitors also, and they have good image quality.
Tanuj, a little
Yes, a little
faster.
faster. Yes,
It's
sir.
12 minutes now.
Yes, sir. Yes, sir. Yes, sir. So, just few points about the cost effectiveness of these scopes. There are no uniform equations that compared these scopes. There was a lot of heterogeneity in the data. With the available data, reusable flexible ureteroscope appear to be more cost effective in high volume centers. Single-use disposable scopes appear to be more cost effective in low volume centers, centers with trainees, public health backed facilities, and case specific, that is lower pole and large burden. But newer disposable scopes may change the dynamics. Sir, should I go ahead with the accessories, or have I exceeded my time?
Little faster.
I'll just quickly, I'll just quickly run through. So basically, accessories can be divided as accessories for better access, better extraction, for biopsy, stents, and others. For better access, most important thing is the guide wire. They allows for ureteric access to establish a tract and to exchange devices during the urological procedures. Most commonly used is the hydrophilic guide wire. It has a hydrophilic coating with elastic nitinol core available as 0.025 to 0.038 inch in diameter. Relatively easy to pass along the impacted calculus. Most commonly used for RIRS, preferably both sides should be soft tip. Super stiff guide wires come in handy sometimes, especially when there's an enlarged median lobe or angle at the VUJ. Problem with commonly used wires like Zebra is that the tips are not radio opaque and they don't have a hydrophilic coating. The hybrid guide wires cover that advantage. They have a super stiff core with nitinol tip and hydrophilic coating. Roadrunner from Cook and Sensor Wire from Boston are examples. And we know about the ureteric catheters. They help us to do a RGP and to pass a guide wire through the kinks. Dual lumen catheter can be of advantage in RIR sometimes, especially it helps in dilating the ureteric orifice. Access sheaths are integral part of RIRS surgery. They facilitate the insertion of flexible ureteroscope, consist of outer sheath and tapered dilating obturator. They are coated with hydrophilic polymers for easier insertion. Outer diameter available as 9 to 18 French with a length of 20 to 55 centimeters, and they'll help in reducing the intrarenal pressure during ureteroscopy. The passage of access sheath should be very smooth. There should not be any force, should not be exerted. These are different access sheaths available. Then there are accessories for extraction, mainly the nitinol retrieval.
This will be
yeah, it will be covered later. So I will just skip.
it.
Yeah. So then if you need to take a biopsy, then there is a backloading biopsy forceps from Cook, or you can get one made from the Indian manufacturers also, which need not be backloaded. Then we know about the stents, the commonly used double J stent and endopallotomy or endoureterotomy stent if an endopallotomy or a dilatation has been done. Thank you. Sorry for exceeding my time.
Thank you for wonderful presentation, Tanuj. Now, without wasting time, I will go to the next presenter. You stop sharing the screen.
I've stopped.
Yeah. Next presenter is Professor Lee Jun, MD Urology from Beijing. He is consultant urologist from Beijing Friendship Hospital, Associate Director of Pediatric Group subordinated to CUA, Director of Urolithiasis, CUA Youth Committee. His main area of interest is endoscopy, more so on pediatric. He does pediatric RIRS, microperc, mini-perc. He has more than 50 domestic workshops, 10 international workshops, and more than 500 urologists trained ultrasound guided PCRL and FIRS. So he had been invited to AUA, EAU, WCE, SIU for several years on pediatric urolithiasis. I am very happy that even I am learning pediatric urolithiasis. I'll be happy to listen. Now I will stop the sharing my screen. Over to Professor Lee Jun.
Hello.
Yes.
I will share my. Yeah, I will share my.
Perfect.
So how long?
Thank you for introduction. But actually, I'm an adult urologist, but I perform most of pediatric cases in China. But today I will talk about the single-use digital flexible scope. Although this is single-use, but I think this is most for adults. Maybe future we will have single-use scope for pediatric. Now, TCL and FUS is the most common treatment for stone diseases. They both have advantage and disadvantage. Of course, now we use more and more flexible for stone treatment, but still, flexible scope has its disadvantage. For example, low stone free rate, and they need pronylation, and also high pressure cause infection, and also low cost. We will spend a lot of money for the reusable scope. Here is a traditional scope. If we see film like this, it means the scope may damage. So if damage of fibers and damage of control part, we will maintenance of the scope, and it will take us money and time. The document side average life for reusable scope is more than 10, but less than 20 times average. In my hospital, we do have reusable scopes, and the life for the scope is around 20 to 50 times per scope. So it's very expensive for us. If we see the film like this, it's sad things for us. And even after maintenance, the life and the performance are not good as the new one. So this is a traditional reusable scope. So we need a friendly scope, and we need a clear scope. Also, we need single use because we don't want cross infection, and also the scope may durable and may cheap. So if altogether, I think the only solution is single use digital scopes. So we get PUSEN. And here is some experience comparison between the PUSEN and the other flexible scope. This is of course the STORS scope. So we can see resolution because PUSEN is a digital scope, so the resolution is good, and also camera distortion. So the performance also good for PUSEN, and also diffraction. This is what we need for flexible. So here is the film for the PUSEN scope. So we got both sides 285 degrees deflection. So it means we can reach most of the areas inside. So if I get more than 300 degrees diffraction, but if with 200 microfiber or basket, PUSEN also can get more than 270 degrees diffraction. So much more than the traditional scopes. And also here is a film we get under the X-ray. So we can see with the PUSEN scope, we can reach stones very easy. And also it has deflection look. You can see us, if we use a deflection look, we can fix the scope and we can erase the stone very easy. But normally, actually, I don't use the lock system quite frequently. And also here is the working channel. Pusen has 3.6 French working channel, just equal with other traditional scopes. And so you can insert 200 fiber with 1.5 French basket together inside the working channel for options. And so here is the total. For visibility, Pusen is quite good. Although less than the reusable digital scopes, but I think because Pusen is cheap and is single use, I think this performance is good. And also the whole satisfaction, Pusen also good, performance good. At least better than the optic fiber scopes. Also, the handle part is light, very light. I have the experience for Pusen, much lighter than the traditional scope because we will hold the scope and also the camera part and also the light source fiber. So very heavy. If you perform operations more than 1 hour, you will feel very tired. Maybe you will think quick finish the operations. But if with Pusen, you will hold the scopes more than 1 hour, 2 hours. But of course, safe is most important things for the patient. And also cheap. Compare with the traditional reusable scope, Pusen means cheaper. Only if you can use a reusable scope more than 60 times, you can get the same cost between Pusen and the reusable scope. But normally we can't use a reusable scope more than 20. So I think Pusen much cheaper than other scopes. So what we got from Pusen, we got no cross-infection because it's a single use. We don't need sterilization, no maintenance because we use one, throw away, and for the other patient, a new one. Friendly, very friendly scopes, very easy to control. And so we will face a new instrument for each patient. So we feel much better than before because before we use reusable scope, we will maybe after 10 or 20 times, we will use an old one and not quite good one. So no infection, no cross-infection is most important for the single-use scope. Of course, we got very clear view. So this is comparison. Nowadays, nobody will use a traditional TV set within your family. So just like this, if you still use reusable scope, compare with Pusen, compare with the single-use digital scope, I think just like this picture. So I think maybe single-use digital camera scope FUS maybe the future. Until now, I know the Pusen, they do have 7.5 French new scopes on way. So maybe future Pusen will not only suitable for adult, even suitable for pediatric, even suitable for baby. So let's waiting for the new Pusen. Thank you very much. Thank you.
Thank you very much, Lee Jun, for the crisp talk. I know you are very experienced. Every Indian thinks only one doubt. If you use only one time, is it possible any time use only one time? You use only for one patient?
You mean with the
yeah.
Yes. In China, we must use if a single-use scope, we must use one patient, one scope.
Yeah, thank you very much. We will go to the next speaker. Next speaker, our next speaker is Dr. Michael Italso from Italy. He is MD urologist from Italy, now working at Vimercate Hospital, Milan, Italy. Special interest in endourology. He has done fellowship with Professor Olivier Traxler, as you all know, the pioneer and the most knowledgeable. SIU fellowship in endourology at NADIAD in India. Again, you know that NADIAD is one of the most prestigious institutes. He got young academic urologist member in EAU urolithiasis section. In fact, he is Petra Eurogroup member, and he has presented several abstracts and videos at international meetings. He is official reviewer of different international journals. He has been invited at many international congresses as hands-on training tutor. Amazing at this age. I have seen his CV, the publications, very great. I switch over to Dr. Michael Italso.
Hello, thank you for this wonderful introduction. Can you see my screen properly?
Yes, yes, clear.
Okay, that's perfect. So thank you, Dr. Chandramohan, and thank you to Dr. Anish Sheta for the invitation. I will talk to you briefly about basket and basketing in flexible ureteroscopy. So unfortunately, we cannot see the crowds, so people who are watching our webinar, but this question is for everyone. If someone knows who is this gentleman, please keep it in your mind. Otherwise, I will tell you at the end of the presentation. Why should I do some basketing? Of course, because sometimes I don't want anything remaining in my collecting system. Sometimes because just I need a stone sample to see the composition of my stones. Sometimes because I want just to make the patient stone free. And there are several scenarios in where I need to use a basket. So just to give you some examples with some videos, when I need to do some basketing, of course, when I need to extract a stone, when I need to relocate a stone, for example, if I have a stone on the lower calyx and I want to relocate the stone in the upper calyx just in order not to do my stone treatment with a banded scope, then I will use the basket. Sometimes I have small fragments and I want to evacuate them, but it's not just that. So I don't think that those fragments can just be evacuated with urine. So I can decide to go for basketing. And there are some specific baskets we will see that are useful in this situation. Then again, sometimes I need a basket just to avoid push-up. If I'm treating a stone in the ureter and I have my instrument into the ureter and I'm doing my lasering there, I don't want the push-up of the stone, then basket is useful. Sometimes use basket to catch a foreign body inside my collecting system. Typical case is when I have an indwelled stand, double J stand that get encrusted and I need to cut it in different parts in order to remove the double J stand. Then I need a basket to remove the pieces that remain in the collecting system. Again, basket can be used if I don't have the right grasper to do some biopsy in the upper tracheary cell carcinoma. So if I need a basket and I'm doing my surgery, I ask to my nurse to give me a basket, I need to know many things about my basket. It's not just a basket. It's just a matter of size, of wire numbers, kind of tip of my basket, what kind of opening do I have, what kind of basket I want. I want a parachute, I want a triceps or something else. And we will see that there is even some more technology helping us during our surgery in basketing, which seems a simple part of my surgery, but we know the urology is made of details and baskets are full of details. So these horrible slides, it's just to show you how it works with baskets. Companies comes with different measures. They give us some measures in centimeters, and those are the basket lengths. So 50 centimeters, 60 centimeters, 70 centimeters, it depends on the brand, of course. Then there are another size, which is expressed in millimeters, and is the diameter of the distance in between the branch of my scope. But the measure that internationally are used for baskets is expressed in Charrier or French. And this is this just showing you the diameter of the external sheath of my basket. So if I say I want 1.9 basket, it means 1.9 Charrier basket, and this is the external diameter of the sheath of my basket. And all different brands are giving you this kind of measures, and I have to keep in mind this. Why I have to keep in mind this? This is really important. The problem is the most important take-home message for all people listening to us. And the important take-home message is just as we saw in previous presentation, baskets, like working channel diameter in almost all flexible scopes is 3.6 Charrier. And I know that with a basket who is smaller than 2 French, I can pass in the same working channel with a laser fiber that is smaller than 270 micron. And once I have the 2 instrumentation in the same working channel, this can be really, really, really useful if I got some problem, if I want to avoid the push-up of the stone, or if I get locked and trapped in the collecting system and I need to cut the wire of my basket. If I have a smaller basket than 2 Charrier, then I can just cut my wires with the laser, and it is really useful in order to avoid some really, really, really horrible complication I can have doing basketing. So what kind of baskets we have on the market? We're full of different kind of baskets. The majority of them are made of nitinol, which is a metal alloy made of nickel and titanium. There is a shape memory, they are super elastic, and we have different shapes for different purpose. We will see briefly all the different shapes. This is the most common basket we have in the market. It's cheap, it's strong, and it's achromatic. So if you're starting your activity, please keep in mind that a normal called no tip or zero tip basket is one of the most useful and most cheap and most easy to find on the market. There are 4 wires and achromatic tip. This allow my the tip of the instrument pass into a banded scope, and you avoid to damage the mucosa of the ureter. Even in this simple basket, we have some differences, because we have some basket that open pushing forward the wires, as some basket they're opening with a withdrawal of the sheets of my basket. So as you can see, we place the tip of our basket in the same point, and one is going forward and the other one backward. So in case of a lateral opening, as we say, to catch a stone, we just place the tip of our basket like parallel to the stone, and we can just roll on the stone in order to catch it. And it's really useful and really easy to do. If we have a front opening basket, then we can use the lasso technique. This is useful if we're in the renal pelvis, for example, and we need to catch some stones and we have space. We can just place our scope, our basket above the stone, then we flip down the tip of the scope and we catch the stone. And this is really, really easy tip to do, but really useful if we have to catch a stone. Then again, we have some, I call it parachute concept. I don't know if you like it, but it's just to show you this kind of basket, which is amazing if we have small pieces of stone made of hydroxyapatite or, for example, uric acid, and it's not really easy to dust because we have small pieces floating everywhere. We can use this kind of basket. They're really expensive. They're handmade, but they allowed you to extract small fragments. So if you're a stone center, then you can put some money in it, but you don't have to use it in your routine. Sometimes we have even this, almost all companies are doing this kind of new concept, front opening basket. And those are useful if we have some stone in calyces and we don't have enough space to pass after the stone with my basket, and we can just get the stone exactly in front of you. This is not mandatory to have this kind of basket, but they're really nice and really useful. And almost all companies right now are selling this scope. As I told you before, the no zero tip basket with a diameter which is less than 2 Charrier can pass into a totally deflected scope. This is a study we did in Paris with Dr. Esteban Emiliani. We'll talk later. And we show that this kind of basket can pass in a 270 banded scope without the need of nothing. And it's really, really useful to know it. Then again, technology is coming to helping us, and this is the little view scope, as you saw before from previously presentation. And this is from Boston Scientific, but I'm sure that even other companies doing new disposable scopes can do something like this. And they did this kind of plug that you can put on your handle, and then you can attach the basket on your scope. And this is really useful because it can allow you to do everything by yourself. So this will just turn the ureteroscopy into a single surgeon surgery, and sometimes you will not even need any nurse helping you, because when you plug this basket on your handle, then with the trigger, you can open and close the tip of your basket. And then it's really useful because sometimes if you don't have a really trained nurse beside you, or a resident, which is the beginning, and you really need to be coordinated, you can do everything by yourself, just pulling the trigger and deflecting the tip of the scope by yourself. And this is really interesting tool. Again, this is not mandatory to have something like this, but it's interesting and it's useful. And as I told you before, urology is made of small things and details, and we all love details, and this is really nice. So another thing we have to know is that hopefully our laser are able to cut the wires of our baskets. So in case we remain locked and trapped with basket into the collective system, an exit strategy, which is beautiful, and we can use it if we can fit both the laser fiber and the basket within the same working channel, is just cut the wire and you can remove the basket and leave the stone inside, and you think in a second time what to do with this. So if you're wondering who is this gentleman of course is Italian. This is my proud. This guy is called Enrico Dormia. Probably you have heard about the Dormia basket. This is the inventor of the basket. Actually, he started to use ureteral catheter, placing a guitar string inside the ureteral catheter, and it was removing stone just under fluoroscopy. Right now, this is not feasible because, of course, you need endoscopic view. But the beginning of the stone extraction with basket was due to this gentleman, Enrico Dormia. So once again, thank you for your attention. I hope I don't excite too much with time.
Yeah, thank you very much. That's wonderful presentation. Especially, I didn't know that self-opening basket with trigger. We haven't yet seen that. Fantastic. Thank you once again, Dr. Michael Talso. Let us move to the next speaker. Dr. Anil Shrestha is a special important person for me, close friend. In fact, more than 50% of the program is designed by Anil, and he is Associate Professor of Urology, National Academy of Medical Sciences, Bir Hospital, and Consultant Urologist in Grand International Hospital, Kathmandu. He is International Journal of Urology and Nephrology Reviewer, Saudi Journal of Kidney Disease Transplant Reviewer, Best Moderated Poster he had in 2018 Eurofair, Singapore, 8 international national publications, invited faculty, demonstrated live surgeries even in my hospital. And to be honest, he has a extremely good memory, and he is a very, very lovable guy, and he is a good speaker too. Anil, over to you.
Thank you, Chandramohan. Thank you.
Yeah, fine, crisp.
Very good afternoon.
Ask the questions in the chat box. Sorry, Anil. Okay, carry on.
Very good afternoon from Kathmandu. Today, I'm going to talk on very specific topic that most of the endourologists, they don't consider it as important when we deal endourological procedures. According to one literature that was published in World Journal of Urology, most of the only very few urologists in the world, endourologists in the world, they are aware of consequences of raised intrarenal pressure during endourological procedure, including PCNL and RIRS. So why are we talking about pressure in RIRS? Because it matters. Because we have to understand the nature of surgery of RIRS. When we perform RIRS, we introduce everything, almost everything from retrogradely from the ureter, which is actually the exit point of the kidney, from where all the urine and irrigant flow comes out. So we introduce and we virtually block the ureter, So from one study published in 2004 in American Journal of Radiology, they have researched around more than 300 ureters with non-contrast CT and found that more than 96% of the ureters are less than 9 French or 3 millimeter of size. And we introduce around 9.5 French scopes, even bigger axis sheet like 10, 12, 14 axis sheet from the ureter. So see this outer ring is the ureter, and the blue ring is axis sheet, and the middle part is our scope. And see the white part between the ureter, between the axis sheet and the scope. This is the space from where the irrigant flow escapes out of the kidney during our procedure. That's why pressure during RIRS really matters. So normal intrarenal pressure is around 12 to 15 centimeter of water. It has been shown in different research published to date. And when we create a forced diuresis, then the intrarenal pressure can rise more than 27 centimeter of water. So what happens when we create high intrarenal pressure during our procedures? We all are aware that if the pressure goes above 40 or 60 centimeter of water, then there could be pylolymphatic backflow. And if more than 60, 80 centimeter of water, then pylosinus backflow. And there can be rupture of fornices and etc. But there is a very interesting finding that was published by Tokas in World Journal of Urology 2018, and they have clearly mentioned that decrease in arterial blood flow was also associated when the intrarenal pressure is high. That means kidney become ischemic after a certain time when we raise the pressure inside the kidney. Moreover, the venous outflow from the kidney also gets impaired, which is more detrimental. The kidney can start swelling up when we increase the intrarenal pressure. So these all effect can be created when we elevate or when we create a high intrarenal pressure during our procedures. So when we are doing endourological procedure with high intrarenal pressure, we are creating artificial renal colic. During renal colic, intrarenal pressure can go as high as 80 to 100 centimeter of water. So even though patient is anesthetized, he is like in a renal colic. So the pain or the distension of renal capsule can be extreme. I found a very interesting paper from China. They have classified complication of RIRS according to modified Clavin-Dindo. And what they have found is infective complication, and most of the complication related to RIRS and the factors contributing to the complications are positive preoperative urine culture, which is number one. Second stands irrigation rate, the irrigation rate that we use for our endoscopic procedure, and of course, duration of the surgery. So irrigation rate should be optimized to keep our complications rate very low. So what are the factors that can affect intrarenal pressure? Apart from irrigation rate irrigation pressure is also very important. And most of the people, they get confused about irrigation rate and irrigation pressure. They are not same. They are not interchangeable. Yes, irrigation pressure can give us good irrigation rate, but they are not same. Even if you create a good irrigation pressure and your working channel is occupied by your accessories, then irrigation rate may still remain low. So they are not same. Another important factor is duration of surgery, use of access sheath, and the working channel occupancy. You know, with the same irrigation pressure, if your working channel is occupied with your basket or with your laser fibers, then the irrigation rate will be low and the intrarenal pressure may not rise very high. One interesting finding about intrarenal pressure is when the bladder gets filled, I mean, when intravesical pressure is high, then it reflects in the intrarenal pressure also. So it's better to keep our bladder empty or not distended during our endourology. That's another reason why with the use of ureteral access sheath, the intrarenal pressure doesn't go that high. It's not only because of the drainage of the irrigation flow out of the kidney, it also prevents bladder from filling up. That's another reason why with the use of access sheath, IRP remains not very high. Another very important factor regarding IRP is the duration of elevated intrarenal pressure. You know, if the intrarenal pressure is elevated for a brief period of time, it's not very dangerous. But if it stays elevated for a prolonged period of time, then there are many changes and many complications that are bound to happen. So in practice, there are different irrigation devices that has been used, and I don't think there is any standard irrigation device that has been recommended by guidelines so far. There are there are individual variations, but what we have to remember is there is a very nice paper from Petra Group. Again, we have two members from Petra Group here, Michele and Esteban, and we should thank them for a beautiful paper that was published in Journal of Endourology in 2017, actually. And they have observed very carefully that the occupancy of working channel, if it is empty, then the chances of rising intrarenal pressure is high. With laser, little less, and with basket, even lesser. And another very interesting findings, what they have mentioned is with hand syringe, 60 ml syringe, the maximum intrarenal pressure was observed. So when we use 60 ml syringe as an irrigation device for our RIRS procedures, we should make our assistant pretty much aware that he or she has to be very gentle not to rise the intrarenal pressure very much. So I personally think this irrigation by gravity is the safest irrigation technique for RIRS in terms of pressure related complications, you know, because when we set up the irrigation height at 40 to 50 centimeter, and when the pressure inside the kidney rises above 250 centimeters, then irrigation starts to slow up, you know, the pressure will not rise above 50 centimeter if we are not using any pump, any manual pump or any other devices. So it is pretty safe. But what is the disadvantage with this technique is when the pressure inside the kidney starts rising, then the irrigation flow will get slower and the vision may get blurred or vision will not be very clear. In that case, what I prefer is I use intermittent manual pump like Pathfinder or TraxerFlow intermittently whenever the vision is not very good. So I think this is one of the safest technique, but I already mentioned there are individual variation, and whichever irrigation technique you are comfortable with, that should be used. So this is the short video. Even with the manual pump like Pathfinder and TraxerFlow, you have to be very careful while pumping it, because the amount of fluid you are displacing while you are compressing the balloon is directly proportional to the amount of fluid you are introducing inside the kidney. So you have to be very gentle. You have to press it gently with 3 fingers, not to rise the irrigation pressure. Whereas if you press it very vigorously, then the pressure might go very high. So this is a small observation that we conducted in our department with the different irrigation flow rate, how the pressure changes in the kidney. Actually, there was a small epidural catheter of 2.9 French, which was introduced with semi-rigid ureteroscope before ureteroscopy, and that was kept outside ureteral access. That is a kink resistant catheter, and it was connected to the transducer, and we measured the pressure in around 19 patients, and we observed that with the increase in flow rate, the pressure can go tremendously high. So our recommendation is to stay below 20 ml per minute as a good irrigation flow with this observation. Still, this is a very preliminary study with a very few numbers. So there has been, I won't say enough evidence, but there are some evidence that use of ureteral access sheath causes some lower in, it lowers the intrarenal pressure in comparison to procedure without access sheath. But the evidence is very minimum. There are only one human study, and most of them are animal and lab studies. And what most of them has concluded that larger the access sheath, lower the irrigation pressure. But again, using larger access sheath, especially in this part of the world, without pre-stenting is very dangerous, because it can cause ureteral damage and ischemia. So you have to balance, you know, if you are using access sheath, then you have to use it very judiciously, not very large. So another very important factor, very important point that should be noted is, if you are using access sheath during your ureteroscopy, you have to be very vigilant whether the irrigation outflow is there or not from the access sheath, you know. If the irrigation outflow is not very good, then I think it's better to stop, because the chances of rising intrarenal pressure is very high. And I have encountered few complications of obstructed ureteral access sheath during RIRS. And another important factor, when we start doing ureteroscopy, when we can't introduce access sheath, we try to go without access sheath. But when we go without access sheath, and if there are narrowing in the ureter, then prolonged surgery should be avoided. Try to make your surgery short and keep your irrigation low, because that narrow part of ureter will hinder the outflow of the irrigation from the kidney, and pressure may go high and cause subsequent complications. So what scope is good for to maintain low irrigation? I think this topic is still to be researched, because there is no evidence. But we can say that digital scopes they have a better vision. Most probably they will require low irrigation rate, and they will help maintain low irrigation pressure, low intrarenal pressure. Again, it is the subject that has to be researched, and we should get some result. And with the permission of my friend from Saudi, it's Saeed bin Hamri, I got a video from his Twitter. It's a furniture rupture that was encountered with a high pressure when he was doing RIRS without access sheath. So the video in the left side is the video of rupture of the fornix during RIRS, whereas the video at the right side, with the drape external view, it's my own video. Actually, I was doing 1.9 centimeter lower pole stone in a 47-year-old female. The procedure was lasted around 45 minutes, and the procedure was perfectly fine. according to our departmental protocol, I was about to perform retrograde pyelogram at the end of my procedure. The procedure went everything fine. At the end of the procedure, I injected 7 to 10 ml of contrast. I should confess that I was in a bit of hurry. I injected little faster than I could feel the pop and the bleeding occurred, you know. This is after digestion placement. Luckily, the patient was managed conservatively. It happened because of the forced retrograde pyelogram, and you can see the pyelogram in the CM view. So when there is a raised intrarenal pressure during RIRS, we can have a fever, sepsis, increased postoperative pain, prolonged hospital stay. We can also have, there are reports of renal damage, subcapsular hematoma, even death related to sepsis. So if we ignore raised intrarenal pressure during RIRS, all the beauties, all the charm of RIRS is gone, you know. Minimal invasiveness, less complications, all these factors are gone. So we have to be comfortable. We have to be very careful. We have to be very gentle. So to conclude, to make our RIRS procedure safe, be gentle. Like in any other endourological procedure, being gentle cannot be replaced by any means. So be gentle. Irrigation under gravity is safest, but you may not be comfortable in all the circumstances. Avoid forced irrigations. Use of access sheath for long surgery can prevent rise in intrarenal pressure. And please check your outflow in between, in the middle of the surgery, just to keep your irrigation flow rate and be safe. Stay safe and thank you.
Thank you, Anil. Wonderful presentation as expected.
Thank you.
Thank you, Anil, for the wonderful presentation as expected. Now I will go to the next slide. That is Dr. Siddhalinga Swami, who is consultant at Preeti Urology and Kidney Hospital, Hyderabad. In fact, he worked more than 3 years with me, and he is heading my second hospital at BHEL. And over there, he has done more than 400 to 500 RIRS surgeries. I'm happy that he is also training faculty at Euromed program, one of the faculty member for VLD, and best paper award in our state conference, and published some articles also at this age. Over to Swami. I will stop sharing. We also welcome Vijay Goli from US as our one of the panelists. Hi, Vijay. He is
Hello.
not. Hi. So we will introduce you at the end of the talks, so, because we connected late, and nice you joined at the very early hours of USA. Thank you very much.
Not a problem.
Yeah.
Thank you, sir.
Yeah. Over to Swami.
Thank you, sir. Thank you, sir. At the outset, I would like to thank my mentor, Dr. Chandramohan sir, and Dr. Anil sir, to giving me the opportunity here. So today I will be having a very small talk on basics of laser settings, both holmium and thulium. So RIRS is the most common procedure done worldwide, as we all know. The laser setting has one of the most crucial factor for a stone-free rate. Both holmium and thulium have different laser settings totally. First, we will discuss about the holmium laser. I will not be going into the details of the machine. As we all know, it contains of the mirrors with the NdAg crystal, which is doped with holmium ions. So before entering into the settings, what we are commonly using, I would like to know about the energy, frequency, and the duration, which I will be using again and again, which will be useful for negotiating the laser settings. So energy is nothing but the force with which you are hitting the stone. The frequency is nothing but the number of times you are hitting the stone, and pulse width is each contact of the laser fiber with the pulse with the stone. Is it a short duration of contact or it is a long duration of contact? So when we have a holmium energy, so in flexible ureteroscopy, we have the lowest energy is 0.2 and the highest is 2 joules. When we use a lower energy, we will have tiny fragmentation of the stone, And if you use a very high energy, there will be large fragmentations. So frequency ranges from 5 hertz to 80 hertz, even in 120 watts machine. So frequency mainly helps in reducing the number of powder, or reducing it to the more dust when number of fragments are formed. If you have a very small calyx and if your laser fiber is at the tip of, or it is just touching the stones, then the fragment is much better compared to the one where the calyx is wide open and the laser fiber is far away. So pulse width, that is short pulse and long pulse. Short pulse is 150 to 350 microseconds. It breaks the stone, but there is increased retropulsion. Whereas in long pulse, that is around 500 to 1300 microsecond, it also breaks the stone, but there are less retropulsion. So Luminous came up with this Moses technology, where they have used the two bubble effect to drag the stone towards the laser fiber to fragment it in a much better way and reducing the retropulsion rates. So we will be discussing the laser lithotripsy techniques because each technique has different laser settings. So first, coming to the painting technique here, these are best for the soft stones, and you need to just place the fiber in contact with the stone and brush back and forth, ablating layer by layer. Here the energy we use is around 0.5 joules. That's the lowest energy possible in a 30 watt holmium machine with a frequency of 10 to 15 hertz. The chipping method is nothing but the same painting technique, but we are coming from the edges of the stone. We will be fragmenting it piece by piece as small as possible. We do it most commonly for the hard stones. Here also the energy will be 0.5 joules, that is lowest, and frequency is 10 to 15 hertz. For popcorning, we need very high energy and high frequency. That is, energy is 1.5 to 1.5 is the maximum energy in a 30 watt machine, and a frequency of 15 hertz, which will make the fragmentation much efficient. Fragmentation, we commonly use it for the bladder stone, where we can extract the fragments or make into multiple small pieces and we can extract them. Energy is 1.5 to 2 joules and frequency is 5 to 8 hertz. So for popcorning settings, the best one is to the most efficient in smaller spaces. Displace the stone into a calyx before popcorning, and no difference is seen between the high power settings. What challenges with the popcorn is we can't do it in the ureter or in the renal pelvis. You have to push the stone into a calyx, and the heat generation, because of the multiple vibrations of the frequency, there is heat generation. So dusting technique, here we use a high frequency at a very low energy setting, the 0.2 to 0.5 joules and 20 to 80 hertz, and sub-millimeter fragments are formed. So I would suggest that there is no perfect definition of a dust, as everybody will agree. Few say it is just the tip of the laser fiber, few say which is floating, few say which is less than 250 micron. But whatever is said and done, if we decide that these fragments are going to pass off without any basketing, without any relook, then we say it is completely dusted. So this can be done by a contact phase or a non-contact phase. In contact phase, we are using dancing or popping or chipping method. In non-contact, we use popcorn or whirlpool effects. So whether to fragment or to dust depends on the individual surgeon experience. But as we move from a smaller to larger volume of the stone, the number of times coming out of the access seat is very difficult. It will damage the scope and also the ureter. So both dusting and fragmentation has advantages and disadvantages. So last one is the pop dusting, where we are combining the dusting method and also the popcorning method, which gives a much better result with a very short period. 120 watt machine at 0.5 joules, that is 80 hertz setting, it gives a pop dusting. So both holmium and thulium are very good for pop dusting, but in holmium we have to use a very high energy one. In our experience, as we are using in the last 1 year with the thulium fiber, since it is introduced in our India, so thulium fiber does a little bit better compared to the holmium on pop dusting. So thulium fiber laser. So just a brief introduction. This is nothing but a fiber which does not has any crystal or anything. This small fiber is around 10 to 30 meter long, which is doped with thulium ions. When the diode laser are connected, the energy is produced from this diode laser, which passes through this fiber. The exit laser fiber will develop the thulium energy fiber there. So this thulium fiber laser has a specific wavelength, which is 1940 nanometer, which is very near to the water absorption coefficient compared to the holmium. So it has better water absorption, better bubbles formation, so better fragmentation of the stones. So these are some of the examples done in our unit. So when we are using the thulium for the same painting technique, we can use the energy as low as 0.025 to 0.1 joule, which is not possible with the holmium, and frequency ranging from 80 to 300 hertz. So chipping method, same, the lower energy and high frequency is used. So technology is same, the method of doing is same, but only the settings of the laser are different. Popcorn, I should say one of the best popcorn method. Whatever the amount of stone burden in the calyx, it will reduce to powder in no matter, because of the very high frequency which you can achieve with this. So energy will be high, 0.2 joules, and the frequency is also high. So fragmentation, as I had already told, just to fragment the stone and extract with the basket, this does a wonderful work. So I'll be sharing a last one where if there is an inferior calcium stone, the patient did not want PCNL. So it was around a 2 centimeter stone. We had to do it in one sitting. So we first used the holmium laser to do the dusting as much as possible, then reduce the fragment as small as possible. Then we used the thulium once the fragments were small. So within no time, we were able to achieve very fine fragmentation and complete clearance of the case within one sitting. So to conclude, no laser settings are universal for a desired endpoint. So 100% of stone free rate must be the aim for the laser setting. Pop dusting is currently popular for the same. Medium stone, dust as much as possible. Popcorn with a very high energy laser setting is very useful in a closed system. We should always remember laser produces the heat. Thank you, sir.
Thank you very much, Swami, for that crisp presentation. And now the next speaker is Dr. Esteban Emilani. When I read his CV, it is a really big CV and really an academician, like Oliver Traxler, consultant endourologist at the Foundation Piguet Hospital in Barcelona. Sorry if I am spelling wrong. Barcelona, Spain. I have been to Barcelona last year. Wonderful place. He is clinical associate professor at the Autonomous University of Barcelona. He was trained under the tutorship of Professor Oliver Traxler and Mahesh Desai sir at MPUH Nadiad, two very important persons in endourology, Nadiad as well as the Oliver Traxler Tenon Hospital. He is member of the Urotechnology section at EAU and published more than 40 articles on endourology being his main area of interest, and also his endourological treatment of UTUC. Now over to Dr. Esteban Emilani. Thank you. Swami, video,
okay.
Switch off.
Yeah, I'm, wait a second.
This is my favorite talk also. Even I practice without fluoro. I love to listen from you, Doctor.
Thank you. Thank you so much. I'm having trouble sharing my screen.
No problem. You can switch on and restart. Switch off and restart.
Okay, I don't know what's happening. So I'm so sorry.
Anil?
Yes.
I just want to ask you a question, your presentation.
Yes, please.
Do you have anything on RGP to say that intrarenal reflux, like nephrogram phase, if you see at the end, does it mean that we have used more pressure? For example,
from RPC?
RGP, retrograde pilogram.
So it's very difficult unless you have already done perforation or rupture, unless you have already done damage. Okay. RPC will tell you anything.
Yeah, Esteban, you are ready?
Okay, yes, I'm ready. Thank you so much.
Thank you, Anil.
Okay, first of all, thank you for the invitation to the organizers and everyone for being here. I'm going to talk about a bit of flexible ureteroscopy, but without fluoroscopy, fluoroless flexible ureteroscopy. I think is a very important advance in what we do nowadays. I think is the normal evolution of flexible ureteroscopy. And this is important because we all know the consequences of fluoroscopy. Think about your colleagues or senior colleagues that you have seen. There's always somebody that had cancer or cataract surgery. You know, I always tell my residents, fluoroscopy gives cancer. We all have seen these cases about the orthopedic surgeons with their cancer in their hands or dermatitis in their hands. This is a very important issue that we should address. Now, the first rule about fluoroless ureteroscopy for me is to place your C-arm. You always have to place your C-arm even if you're doing fluoroless ureteroscopy, because safety is the most important thing for our patient. So remember this. Now, we have published recently, you can see here the reference, how to do the fluoroless ureteroscopy, and I want to address this. First, you have to take a look to the checklist. The checklist is the most important thing to do preoperatively so you can do it right. So I'm going to summarize a little bit the checklist. First, you have to check very well your images. Probably if you have this kind of cases, a horseshoe kidney or a fusion ectopic kidney, going fluoroless is not the smartest way to go. So check the images and select very well your patients for doing this. Now, the patient positioning. This is how I position my patient. I always do lithotomy position. I place a table next to me to put all the instruments, and I always systematically put my C-arm in the right hand of the patient and my screen on the left side of the patient. The important part about this is to avoid putting metal in the field of the C-arm. This is important because you will avoid extra radiation that you don't need. Okay, so be systematic. Now, protect yourself and protect your the people in the OR. Use lidded glasses, lidded gloves, neck and body aprons, as you can see here in my colleague. And I try to use always dosimeters. It's very important to check your activity. We have 3 dosimeters, one in our hand, one next to our glasses, because we want to see all the fluoroscopy getting into your eye, and one that we use below the apron. I just put it above the apron just to show you, but one that we use below the apron. This is very important also. Now, when you place the C-arm, I try to place it always in the same position and systematically, and I try to have an ultrasound in the OR because it can give me some help, for example, by placing the double J stent or at the end of the procedure. So if you can have an ultrasound in the OR, or bring it up because you'll have an extra tool. Now, the position of the C-arm is very important because if you're doing fluoroscopy, try to avoid these kind of situations where you do lots and lots of shots without any sense. So try to position very well your C-arm when you know there is the site of fluoroscopy that you want. Now, take a look at the settings that you're doing. Use single pulse. This is very important. It doesn't matter if you use single pulse compared to continuous pulse. You have less radiation exposure. Reduce the frames per second and reduce the height of your C-arm. Place the C-arm as low as possible. This is really important to reduce the radiation exposure. I always use the pedal. I like to use the pedal instead of a technician. I think this reduces also radiation exposure, but set your C-arm before doing this. And said your C-arm is also doing collimation. Collimation is very important to avoid this. So there's two kinds of collimation, for example, that I can do in my hospital. One is the round collimation, that you reduce the exposure of the C-arm, and then is the lateral bars that you can do it. So collimate before you do some fluoroscopy. Now, in order to do the procedure, you have to replace fluoroscopy with endoscopy. What you don't see with the C-arm, you will see it with your endoscopy. And use your tactile feedback. This is why I recommend this I recommend that this technique can be done with the most, with people that have a little bit more experience than people that are beginning. People that are beginning, I will recommend to use fluoroscopy to feel your tactile feedback, to know where you're doing, what you're doing, and to use fluoroscopy to be aware what you're doing. But if you are a senior or you have had some experience, do it with endoscopy. So for the wire placement, I always place my wire without fluoroscopy. I place the wire until I feel no progression, until I feel the stop, or until the orifice kinks or moves away. As you can see here, in this point, the orifice moves away, so I know that I'm in the kidney. Also, I'll try to use Terumo-like guide wires for this. This is an Amplatz guide wires, but I try to do it. And once you feel the stop or the kink of the orifice, you can check the length of the guide wire. If the length of the guide wire is in the tip of your table, it usually means that you are in the kidney. So these are two examples on how you can control this. Now, you have to do the ureteral assessment. You have to know that you're in the kidney, that there's nothing in the ureter, so you can place your access sheet without any problem. Always do it systematically. And then to place the access sheet, you can place the tip of your semi-rigid scope at the UPJ and then measure against the access sheet where are you going to place it. So you won't pass the UPJ and you won't damage the ureter and the UPJ while placing the access sheet. So this is how I do it. I know that my 35 centimeter access sheet is the same length as my short semi-rigid ureteroscope, so I always have it in control, and I just place my access sheet, and I shouldn't feel any resistance. If I feel any resistance, I will just stop. Now you check the kidney systematically from the upper to the lower calyx, because you won't do any fluoroscopy. So check the kidney systematically, because you're going to do this at the beginning and at the end of the procedure. Then perform the ureteroscopy as usual. You can just you don't need fluoroscopy for this. You perform the ureteroscopy as usual, and then you check systematically again the kidney from the upper to the lower pole, and then the ureter. This is really important to see if you have done any damage and you have any stones and you left any stones behind. For the double J placement, I do two things. You can do it with ultrasound, as you can see here, where you can see the guide wire, and then it will disappear while the double J is going up to the kidney. You can see here in the image, or you can place it with endoscopy. When you leave the kidney, you know that the guide wire is in the kidney, so you can place it just with endoscopy. Now, when to avoid fluoroless ureteroscopy? First, if you have an impacted stone like this, you don't know where the orifice is, you don't know where you're doing, avoid fluoroless ureteroscopy. There's no need to do it here because you will do more harm. If you have a very difficult ureter, very kinked, like an accordion ureter, don't do fluoroless ureteroscopy. Be aware of where you are. Safety first, my friends. Then, If you cannot find the stone, obviously use fluoroscopy because you have to treat very well the patient. So this is why the first rule is to place your C-arm, because you don't know what you're going to find. And if you have difficult cases, a ureteral stone, if you're doing encrusted stents with flexible ureteroscopy, if you're doing endopilotomy, or if you're doing a difficult case, as this first case is a horseshoe kidney, don't do fluoroless. Have it always in your hand for difficult situations. With this, you can reduce up to 80% of the radiation exposure. 86%. 86% is a lot of radiation, a lot of radiation. And it can be possible in up to 90% of the cases. So try to do it. This, you'll have similar operative times, similar results, and similar complications if you follow the literature. So it's something that we should think about. And I think that's it. Thank you very much for your attention.
Thank you very much, Esteban. Wonderful presentation. Just to add, even access sheet when we use, we pass through the ureteroscope and directly under vision we push. That is what the point we are using for last 3,000 cases. But this will be done only with wolf ureteroscope and access sheet of 28 centimeters. It snugly fits even the guide where water doesn't go. It's like visual obturator. But anyway, your points are really important, which have to be practiced in every case. Thank you very much for that nice presentation.
Thank
now,
you for the attention.
I will go to the, can you close your screen, Esteban?
Yes, absolutely.
Yeah, thank you very much. So now I will go to the next talk. That is myself, Anil.
Yes.
As a co-host, I can introduce myself, but I need to introduce.
It's my honor to introduce the main man behind today's webinar. It's Dr. Chandramohan Vadi from Hyderabad, Preeti, Managing Director of Preeti Hospital, Hyderabad. Actually, 2 Preeti hospitals in Hyderabad. And he's more focused on pediatric RIRS, laparoscopy, and supine PCNL. He has conducted international, national level live operative workshops in RIRS, mini-PERG, and uretroplasty in his own hospitals. He's a course director for 6 months endourology fellowship program at Preeti Hospital, Hyderabad, demonstrated more than 30 live surgeries of RIRS, PCNL, and laparoscopic surgery nationally and internationally. I am very glad to say that he has come to my center also to perform a live surgery and give very didactic lectures in 2017. More than 10 international and national publications, including RIRS in 4 months old male boy, which was published in December 2019. And he has presented a video on RIRS in 5 years old child in EAU Congress in Denmark. So please, Dr. Chandramohan Vadi, for your talk on RIRS in children.
Thank you, Anil, for that presentation. Now I will speak on RIRS in infants and children. As you know, pediatric stone disease incidence is rising. Treatment guidelines constantly are changing. ESWL and PCNL were the standard of care, or the standard of care, will going to be the standard of care, but with addition of inclusion of RIRS as an alternate option, less complications and comparable SFR with PCNL, but technically challenging in children. Anatomical aspects, if you see normal caliber of urethra, it is less than 8 French in 1 year. Up to 10 years, it is 8 French tight. 8 French, but we insert 10, 12, 14 access sheets. Bladder capacity is 150 ml, less than that in 1 year baby. It will go up to 250 maximum. Bladder fills very fast in children while doing RIRS. Normal caliber of ureter is also very, very important. It is only 7 French in very small children, maximum 9 French. So you have to keep these 3 slides in mind before you do the procedure. Evaluation in small children. Small children, ultrasound KIB urine culture is routine. Only difference is metabolic workup. Most of the times I keep a separate flyer for the patients to get it done in the lab. We cannot remember sometimes these, better to have on the paper. Technical aspects are very important. Low doses CT, usually the CT picture will be slightly less quality. That is fine as long as you can interpret the anatomy and the stone. The external genitalia are very small, legs are small. You don't need stirrups in most of the children. All you need is gentle strapping with cotton so that they do not be overextended or underextended. If you see the small external genitalia like this, they will be too small. You have to have good light before you insert. Many of the times you put the scope in the vagina in small children. It hurts, it damages. You have to be careful. In male children, the prepuce has to be retracted carefully. You can do dilatation in female children little easily, but in male children, you cannot dilate more vigorously except submeatal navicular fossa region. Access sheath insertion, we use with rigid ureteroscopy. Whatever the method used, before that assess the urethra with 6 by 7.5 ureteroscope. Without that, directly inserting is disaster. Injuring to the urethra cannot be replaceable. One side ureter injury, you can have Boyari, you can have reimplantation. But once damaged urethra, particularly in male children, disastrous. Ureteric access sheath placement better in stented patients, no doubt about it, especially less than 2 years. Stented is better than dilatation because it causes perforation. Sheathless RIRS you have to do more often in children, and it is difficult because with small penis, if you go inside and manipulate, it may not reflect what exactly you want. In that case, pubic symphysis you have to take as God a little bit, but still sometimes too much scope will be outside. That is a difficulty. Bladder drainage is very, very essential. A small needle suprapubically we used to use, but that may hurt the bladder or your flexible scope or your access sheath. The aspiration with intracath is very easy. One assistant will sit and continuously aspirate. If the water is coming nicely, that means pressure in the kidney is less. As Anil told, outflow is the most important factor, especially if you are not using the access sheath. Normal male urethral orifice looks like ureter, maybe sometimes lesser than ureteric caliber. Orifices post-stented, they look like in adults. Fortunately, all stented ureters behave very well in children, except the length is smaller. If you have kinks, this is the problem. Flexible scope can kink at the UVJ, at the PUJ, and if you force, it can perforate, it can tear, it can avulse. No excessive force. Always be on the stiff guide wire. Guide wire, 2 guide wires acts as a railroad. It is very safe to use 2 guide wires so that you pass smoothly, especially when you are planning for basketing. Certain maneuver like stretching of the abdominal wall, merge maneuver, especially in the upper ureter, very essential. Do not force when the respiration is very high respiratory rate. Ask the anesthetist to stop, do merge maneuver, gently pass the guide wire, then thread over that. RGP better to avoid if you wanted to do minimal 2 ml, 1 ml contrast. Better to avoid if you have a clear-cut information on the CT. Access sheath angle, the moment you insert, no time it reaches upper ureter. You have to be very careful. 28 centimeter itself is long. You can go up to 16 centimeter from Cook. More you go high, more you cannot operate freely. basketing is mandatory to analyze the stone. RGP at the end, I recommend with my experience of last 7 years doing children, because it will tell whether any complication has happened or not, particularly PUJ, so that you can keep the stent for a longer time. Stents in small babies, we use 16 centimeter, 3.5 French, available in our hospital. Some of them questioned why 16 centimeter. There is less than that is not available in India. So we use commonly 16. Problem with 1 year babies is too much coil will be there in the bladder. Pediatric anesthesia ventilatory settings, including the ventilator, are different. I have to buy separately with the low settings 50 ml in the ventilator. Ventilatory settings, I am not going into the detail, but better your pediatric anesthetist should be there than regular anesthetist. It makes a lot of difference because they cannot reduce the respiratory rate, they cannot reduce the tidal volume as we expect in adults. There are no specific flexible scopes available separately for children except coral starch. I am lucky to use last few months. It is only short length, no diameter change. That means outside your small penis, if the length is less, your performance will be better. Post-operative care, the definition of sepsis is different. Total leukocyte count up to 30,000 is normal in less than 1 year baby. So you have to involve pediatrician, or else you should gain the knowledge on a regular basis. It is a pediatric anesthetist, pediatrician, intensivist, nephrologist. Everybody should come into picture. Nephrologist for giving the dosages, especially antibiotics which are nephrotoxic. In my experience is 62 cases in the last 1.5 years which I have written this paper. Less than 2 years, 8 children successfully. Less than 2 years is very important because their external genitalia will be very, very, very small. Once the child crosses more than 7 years, it almost looks like adult. So complication rate is 38%, but most of them are fever. Fever is a major complication as per as literature. Provided you treat appropriately, it may become, it may add to the morbidity. Grade 4, grade 5 like ureteric injury, perforation are rare in our study, nil, because I stent in all the cases. I stent in all the cases. I do not mind one extra setting, but I don't want to damage the ureter. In my infants, less than 10 years, less than 2 years, I have done 10 cases, 2 failed, which I converted into mini or micro perc. 87% is success rate. Usually uric acid stones I have seen. Metabolic evaluation showed hyperuricosuria and hyperoxaluria in these children. Review of literature, it takes less fluoroscopy time in BMC urology, no doubt. Complication rates are comparable to PCNL, maybe slightly less, published in Journal of Urology by Saad K.S. et al. Risk of ureteric injury is more than PCNL, 3 to 8%, published by Evan Chen from urolithiasis. Hospital stay is definitely less. In USA and other developed countries, they are discharging on the same day, but we discharge on the next day night or next day evening. And comparable SFR, definitely if you spare time and do all the proper precaution to fragment the small stones, it will be comparable to PCNL. In infants, there are 2 papers. From June Lee only, this paper recently I have studied, is one of our speaker today. It is highly efficient, minimally invasive and reproducible surgery. With this, I will show 1 or 2 videos and then conclude my talk. This is the 4 months male baby who presented with raised creatinine, anuria, bilateral ureteric stone and kidney stones. Always typically remove the prepuce, don't force with phimotic this thing. It is post-stented. Even then, I had a lot of problem in accessing the PCS, you should be careful in passing these wires. Don't lose the wire also. Thermoguide wire usually slips. When you don't pass the flexible scope easily, then rigid ureteroscopy can be done. This is the method how the bladder is drained. See, it is not going easily at the UVJ. Then slipped. Then I used rigid scope for 2 minutes so that even post-stented, we passed 2 guide wires. And then now I have removed and threaded over the guide wire Flex XC. Once I went inside, these are the stone. This is the large stone. You will not have too much space for fine dusting. You have to do popcorn and don't inject water more. Too much vision is not required. At the end, RGP normal. Because the child has anuria, I thought of doing other side also, ureteric stone. This time I faced problem in the upper end of the ureter. This is the stent which is removed. When I passed above, the flexible scope was going like this, but in the upper end it was not going. Dangerous. It cannot slip, it can perforate only. Then I have to use an extreme maneuver to keep the ureteric lumen at the center and then could pass it. All these maneuvers have to be done extremely careful. You observe my hand. I am using the pubic symphysis of the patient to maneuver it because the penis will not be able to catch the penis so easily. So with this, at the end, we did RGP and then it showed dense nephrogram phase. That means when compared to the right side, left side has little raised pressure. Now I pushed the stent inside, then in the post-operative CT for academic purpose is done, and that is normal. This is published in December in Pediatrics Elsevier as case report. Now coming to the 1-year female baby, just to show the female, in these children, dilatation is easy, but we should not over dilate. This is the last dilator I am using. Once this dilatation is done with a lot of jelly, careful insertion of the ureteroscope, inspect, pass 2 guide wires, and then flexible scope, just pass over the guide wire, then remove it. And bladder can be drained with feeding tube in female baby because you will have space. This is calcium oxalate dihydrate stone and can nice painting with powder. Avoid injuring the guide wire because you will have very less space. If it is coming in your view like this, you can pull a little bit, but don't lose the outside guide wire because PUJ will be little mobile. If you have a guide wire, it keeps it straight. This is the calyx, this is the powder, and at the end, you do RGP if you wish, otherwise not necessary. We use 3.5 French stent, CT normal. Now, next case is 5 years male, right large renal calculus, where I used both homium as well as thulium. And here, ultrasound, you should be ready with supine or prone PCNL also, because sometimes large stones when you take, it may not be possible technically to do the entire procedure. This is a stiffer guide wire. I am passing 12/14 access sheath, which generally not recommended, but for academic purpose, I used Flex XC and then C access sheath was high. Now I am using one layer by layer. This is the classical I do. Textbook, you take one paper out so that you don't reduce the surface area of the stone. This was totally occupying the pelvis. So you remove one layer. At the end, it becomes thin and then it becomes fragmented. Then you have to go for pop dusting. Go for pop dusting later part of it, in the last part. Don't go in the beginning. This is the basket end circle I am using. And at the end, small fragments, low energy, 2.5 you use and then fragment it. Now this is the last case I want to show. Horseshoe kidney, large stone. See, this is the way access sheath goes. In none of our patients, submeatal stenosis has formed because everybody asks that. It's an important question. You put a lot of jelly. adequately calibrate. If you cannot, don't do the case, just convert it into PCNL. In children male, the main limiting factor is urethra of the male. In female, that I have not noticed, even the feeding tube goes. See here, after doing half of the case, is stomach part of the stone, I was not able to do. I was not able to do basketing. Then I used high frequency laser. As Swami said, if you use more frequency, it wobbles. See, now I am using high frequency, vision will be disturbed. Whenever you use high frequency, vision is less, but kidney, the stone wobbles, and I could enter into the inferior calyx. So with that, I could avoid PCNL. With experience, you will know what type of setting at that level you have to use. Sometimes relook is also important. This is the RGP at the end, showing no intravasation, no extravasation. This is the last slide where I tried in a small child. RGP in the beginning showed perforation and extravasation. Immediately I switched over to supine PCNL with Valdivia position, then I could finish it. So we have to be careful. Even though SFR is comparable to PCNL, it has less hospital stay, less radiation exposure. First time I am using a negative slide, technically challenging, multiple sessions needed, longer operative time. You should know which patient to be chosen wisely. Without the teamwork, it cannot be done. Dr. Ramakrishna, Dr. Swami, Manas, Dr. Hemnath and Soundarya are my team of consultants. And these are my 2 hospitals. And you can use unedited videos in my YouTube channel. You can watch whenever you want. Thank you for giving this opportunity. Anil, thank you. I am stopping sharing.
Thank you, Chandramohan.
Yeah.
Now
I will go to the next talk, Anil. Yeah.
Yes, next talk, please.
I go to next talk. In my screen only, it is there. I will just 30 seconds. Now, the next speaker is Dr. Kandar Parikh. There is no need to introduce Dr. Kandar Parikh, sir, in India. He is also one of my teacher. I learned initially from him. He is the director, Sham Urosurgical Hospital. He is exclusively focusing on RIRS. He is council member West Zone, secretary Gujarat Urology Association, treasurer West Zone Urology, secretary West Zone Urology, council member USI, associate international board member ULIS, chairman Advanced Endourology Conference, which all of you might be knowing, conducted various workshops, and in fact, next year, our national conference, all of you please should come. How well he conducts, we will watch. He is a mentor for many of the people, not only CMAST and Euromed. With this introduction, over to Kandar Parikh, sir. Kandarp sir, unmute yourself. Kandarp sir, unmute.
Yeah. Okay. So good evening, everybody. And thank you, Dr. Chandramohan, Dr. Anil, for the great opportunity. In my mind, RIRS is the easiest surgery to learn and operate. But there are some complex situations where you require meticulous planning and good experience. So in next 10 to 12 minutes, I'm going to walk you through some of the complex situations we face when we do RIRS, but still it is feasible.
Sir, your face is partially cut. Just readjust the camera so that in the live session. Yeah, thank you very much. Little more.
Okay.
Yes.
Okay, so fine. I'm going to share with you some of the complex situations, and the situation becomes complex when there is an abnormal anatomy of the pelvic alysis system, when the kidney is anatomically abnormally located, especially ectopic kidney, horseshoe kidney, malrotated kidney, and when there is an abnormal anatomy of the ureter or urethra. Sometimes we have a patient with the abnormal body habitus also. Stone in a callicial diverticulum is always a challenge. Can be tackled with the PCNL, but RIRS is also feasible to do with callicial diverticulum. And of course, Dr. Chandramohan has very well covered pediatric cases. Again, it's not very simple to do RIRS in pediatric cases. Now, the stone in the lower calyx has always remained a challenge with RIRS. If you look at the guideline of EAU and AUA, the stone less than 20 mm in size can be tackled very well with RIRS. But when it comes to lower calyx, they also recommend that one can go for mini PCNL or micro PCNL or maybe a conventional PCNL. But I believe that when there is a stone less than 20 mm in lower calyx, I think it's perfectly feasible to do RIRS, because my plan always is to grab the stone and put it into the upper calyx from the lower calyx if the stone is small and if the anatomy of the calyx is good, or else I fragment the stone in multiple pieces, 4 or 5 pieces, so converting a large stone into a small stone, and then you can put it into the upper calyx and do the rest of the job. So for me, that lower calyx stone is now as good as the upper calyx or middle calyx stone. Look at this anatomy. This is, I think, very, very crucial. Infundibulopelvic ligament angle. This is the most important part. If it is less than 90 degrees, in that case, the entry into the lower calyx sometimes becomes difficult. And even if you enter, it is difficult sometimes to face your laser tip at the stone. So in that case, if you have a possibility of having a round tip laser fiber, I think probably it will help you more. When the infundibular length is more than 3 centimeters, entry may be easy, but then it's always better to dust this stone into this stone completely rather than trying to grab it and put it into the upper calyx and put a stent and come out. If the infundibular width is less than 5 millimeter, your entry into the lower calyx is difficult. Now look here, on this X-ray, though the anatomy looks a little complex, but here the angle of the lower calyx is very nice. So I could enter very easily with my scope. Again, the infundibular length is also not a big problem, and the width is also very large. So in that case, from the stone in the lower calyx was grabbed and put it into the upper calyx in a comfortable position, and I could deal with the situation. In this patient, there are 2 problems. If you look at calyx, the infundibulum of the upper calyx is very, very long, and if the stone is here, the medially facing upper calyx, then your scope has to travel like this, walk through the upper calyx, and go here. So this is going to be a little tricky situation for you. Similarly, when there is a stone here in the lower calyx, you can see the angle is very bad. So this is really a tricky situation. But still, it could be, I could do it with the help of a round tip laser fiber. Look at the anatomy of the now ureter. Sometimes you are likely to face the severe kinking of the ureter. Here also it's a very, very bad kink. Here there is a kink at the level of almost at the level of the UPJ. So these are the difficult cases. In such cases, what I do is I try to give a little head low position. Secondly, to use 2 guide wires. Normally I don't use a safety guide wire. To use a safety guide wire, and the working guide wire is a super stiff guide wire, so that will try to help you drain to straighten the kink. Sometimes I pass a ureteric catheter over the guide wire and completely drain the system before I proceed. So sometimes, because of the sagging of the kidney is also prevented. Sorry? I can't hear you.
Sir, please go ahead. It is disturbance from someone. Is there, sir? There is some another sign in from your name.
No, there is nobody from my.
Dr. Chandramohan sir, can you mute the other from where sound is coming?
Please, please do that because I am the only one who is using it
Yes.
at this moment. Okay, fine, no problem.
I have muted, not much disturbance to me. I have muted everybody. I will check again, no problem.
Yes, sir.
Okay, fine. So now, and then the third maneuver, what you can do is that you can lift the kidney from the back and push it slightly. So that can also help to straighten the kink. Now, look at this case. This is a pelvic kidney. There is a stone in the lower calyx. So when you put your scope has to travel like this, go up right into the pelvis. So this much part is not difficult. So now if you have a stone here in the pelvis, I think you can usually finish it. It's like just a regular case. If you have a stone in the upper calyx like this, here also it's not a very difficult job. The only problem here is this stone in the lower calyx, because your scope tip has to deflect like this and then deal with the stone. Now, if you see here, this is your scope in the ureter. Once it has come into the pelvis, then it has to deflect. You have to deflect the tip, and then now you are seeing the stone. Similarly, your laser fiber also has to travel through your ureteroscope like this. So sometimes it is extremely difficult to deliver the energy. So I am showing you a small video of a case where there is a stone in the lower calyx in the pelvic kidney. The first step which I do is in such a case is to do a dye study, to delineate the pelvic calyceal system, and then insert guide wire. It is difficult to retain 2 guide wires in this patient because sometimes it slips out of the system because of a shorter length. Now here over the guide wire, I have backloaded my scope and my scope has entered here. Now you can see that there is a stone in the lower calyx. This is posteriorly facing calyx. So sometimes lasing is also very, very difficult. Here I'm using a digital scope. Thankfully, the fiber comes out at 3 o'clock position. Here I'm trying to, if the stone is small, you can try to grab it with the basket. Once you have grabbed the stone with the basket, then try to put it in a straight course, and then your job is easy. Like in this patient, I have dropped it into the upper calyx, and once it is dropped into the upper calyx, you can, like a regular case, you can do a laser dusting. So for the planning of the anatomical abnormal kidney, I always prefer to do a pre-standing. That will make your job easy. Secondly, use a super stiff guide wire with the floppy tip. Availability of the short ureteral access sheath is very, very mandatory if you want to use a ureteral access sheath. RGP normally we do not do in a regular case, but in this case I'm going to do RGP, all anatomical abnormal kidney, to delineate the ureter and the pelvic calyceal system. And if you have possibility to have both flexiscope and a digital scope, that is that will certainly help you. I'll show you a short video of a calyceal diverticular stone. In case of a calyceal diverticulum, what you first do is a flexible ureteroscopy and try to find out the ostium. Usually, sometimes it is very difficult to find out the ostium. So you do a dye study that will delineate the entire pelvic calyceal system as well as the calyceal diverticulum is delineated. Then try to look for the opening or the ostium. If you can see the opening, in that case you have got 2 appropriately sized opening. In that case, you might put a small incision. I prefer to put multiple shallow incision in order to enter into the calyceal diverticulum and then deal with it. If you cannot, if the opening is very small, in that case, probably sometimes you can try to put a guide wire. Like here, the guide wire is placed in the calyceal diverticulum. Try to do a balloon dilation of this area. Of course, this is extremely difficult, but sometimes it is possible. Once the balloon is dilated, in that case, your entry into the lower calyx, calyceal diverticulum is going to be easy. And then, or else you can put an incision and deal with that. If you cannot see the opening, in that case, you can do a methylene blue test, or what we call is a blue spritz test, where the methylene blue is injected in the pelvic. Here in this patient, my scope is at the level of the upper calyx. In a case with the calyceal diverticulum, I could not see the opening. You can see that there is a dye study which was done to delineate the pelvic calyceal system as well as the diverticulum. Here I am trying to look for the diverticulum opening, which I am unable to do that. So I injected some methylene blue in the pelvic calyceal system. Now the methylene blue which got collected into the calyx, now it shows ejection of the methylene blue. Once you see the ejection, you know that this is the ostium, and then you try to put the cut. And once you put the cut, the diverticulum opens up, and then very soon you will see small stones. And both the stones can, in this patient, there were 2 small stones. Here you can see the stone here. So both the stones were seen, and then I dealt with it. It's important that you use a laser setting of about 1 joule and 10 to 15 hertz. The incision has to be shallow incision. Don't put a very deep cut, otherwise sometimes it will bleed a lot. Similarly, in this patient, we had a calyceal diverticulum in the upper calyx. And you can see that my scope is looking at the diverticulum. I could see a small opening of the diverticulum. So I thought of, this is the opening. So I thought of passing a guide wire through it in order to dilate this with the balloon. So this is the guide wire going in the calyceal diverticulum. Sometimes it is extremely difficult to retain that guide wire into the diverticulum. But here in this patient, I was fortunate to do that. And then once this is done, I passed the, you can see that there's a guide wire in the diverticulum, and then I pass the balloon. Here the balloon is, you can see the 2 markers of the balloon. The balloon is sitting at the level of the calyceal diverticular neck. And then once the dilatation was done, you can see the nice opening is seen, and then I could enter into this. So this is how, then the job was easy. You can dust the stone, or you can fragment the stone and retrieve the stone fragment. So I think to perform RIRS is technically feasible in a complex situations also, and it has got all the advantages of minimal access technique, so that there are less complications. It is very much result oriented, and of course the surgeon's experience is very, very crucial. The procedure is patient and surgeons friendly, so I think you can extend the use of RIRS, or you can extend the indications of RIRS in a patient where there is a complex situation. Of course, the wear and tear of the scope is more as compared to the normal. And if you have feasibility, or if you have possibility to use a single-use scope, I think it is better to use it. So thank you very much. And I finished with my talk. Because of the limitation of the time, I could not cover horseshoe kidney and malrotated kidney. So Dr. Chandramohan, thank you. I'm done with my talk.
Yeah, thank you very much, sir. That is a crisp talk. You have really limited time. And I have seen you one time in live conference, in your conference, where upper ureteric stricture was there. You did balloon dilatation and proceeded. I might have not dared at that time, but successfully it proceeded. And then you stented without any complication. You are expert. Thank you very much, sir. Now I will, can you close the screen, sir?
Yes,
I will go to the share screen. Now, for all of you who is viewing, nearly more than 300 people, 200 on the Zoom platform, and more than 100 people in different Facebook platforms are watching still now, last two hours. This is our upcoming programs: A to Z PCNL, A to Z laparoscopy, A to Z urethroplasty. One small request, please, we have changed this time 3:30 to 5:30 p.m. I feel it is comfortable. Please give your feedback either personally to me or in this platform, whether 3:30 is better or 5 o'clock in the evening is better. Sorry for the interruption. This is an announcement from our hospital. Now, next speaker, Anil, please introduce your friend.
Yes, thank you, Dr. Chandramohan. I should say we are very honored to have my very good friend from Turkey, Ilorin Tanidi. He's an associate professor of urology at Marmara University School of Medicine. He's director of endourology and stone disease division. He specializes in urinary stone disease both in adults and children. His current research interests are mainly prospective, retrospective clinical trials on endoscopic stone surgeries, urinary markers, and patient-reported outcomes. He is the project director and associate editor at Europedia, holds scientific contents like webcasts, abstracts, posters, surgical videos, hands-on training, videos summarizing the latest meta-analysis articles, etc. He has several publications in peer-reviewed journals and in textbook. Over to you, my friend. You, Lauren.
Thank you. Okay, I guess you can see, right? Thank you for the kind invitation. I'm honored to be here. It's a great pleasure to be in the faculty. Can you hear me, by the way?
Hello,
Can hear.
Anideep?
Can you hear me?
We can hear you. Your presentation is also crisp.
Okay.
For the participant, don't miss the last talk, which is on sterilization, which is also very nicely made by Manas. Sorry, take over, Anideep.
Okay, so I'll be giving a lecture about complication of retrograde intrarenal surgery. Actually, some of my friends had already talked about them, but I'll try to make a brief talk. I have no disclosures to make. This is the biggest data that we have. It's the data from the Clinical Research Office. It holds more than 12,000 patients, and this publication tells us that the overall complication rate of ureteroscopy is not too much. It's only 7.4%. However, if you do a flexible ureteroscopy, the incidence of complications is more 1.5 times greater than a semi-rigid one. And the complications which had been listed in this publication are bleeding and perforation and failed access in the majority for the intraoperative complications. On the post-operative complications, bleeding, fever, infection, septicemia, pain, urinary retention, and stent displacement were listed. Some of these complications actually don't look like a severe one. However, when you put them into Clavien score, for example, the bleeding, some of them actually need further treatments with endoscopic, radiologic, or surgical ones, which means actually they are severe complications. When we talk about these complications, they can be, and there can be an incidence. There can be a pre-operative or post-operative early complication, which actually can also be divided into minor and major ones. And we can also list the complications as post-operative late complications. What are the things that we call as incidents? They actually are not complications. They are the problems that we face. For example, having a difficulty in access, failure of an equipment or an instrument, migration of a stone, or malposition of a ureteral stent. Actually, these do not harm the patient, but they can lead to an increase in operative time, and that they can also lead to several auxiliary interventions afterwards. About the perioperative complications, the majority of them are minor complications. They are bleeding, thermal injury, or mucosal perforation. However, the major ones are the ones which threatens life or which needs a kind of intervention, like lesions, ureteral lesions, ureteral lesions, perforations, avulsion, extravasation, and death. Here I want to show you the minor complications. On the left side, we see a mucosal perforation. On the right side, we see a thermal injury. and in the middle, there is a perioperative bleeding. Bleeding is important. The others actually do not have severe harm. However, with bleeding, you can obscure, we can have an obscure in the vision, and the operation can be delayed, or we can postpone the operation. Another trick to overcome this vision problem may be using 100% of contrast material from the injection port from time to time can increase the vision. As I told you, bleeding is underreported in these series. However, stone burden and CT attenuation of the stone can lead to has a correlation with the hematuria, has a correlation with the bleeding. Force that you put on the intrarenal pressure, if it exceeds an amount, and mucosal injuries are the main causes of bleeding. Dr. Olivier Traxler has introduced a scale for the ureteral wall injury, and grade 2 and 3, which actually holds mucosal injury and full thickness injury, are listed as high-grade ureteral injuries. And with Dr. Manoj Monga, last year they published this prospective data, a series which has 446 patients, and overall the high-grade lesion rate was only 12.5%, and the stricture rate in this high-grade lesion was 1.8% in a median follow-up of 3 years, which means it is very rare. These lesions actually do not mend much. Here we can see several complications from grade 1 to 3. What we do if we have grade 2 and 3 injuries, we only place a JJ stent and leave it there for 2 weeks. And here are the fluoroscopy images of other patients. To have less bleeding or to have less problems, less perforation, you have to have a decrease. You have to decrease the intrarenal pressure. The best way to do this is to use a ureteral access sheet. The patient on the right side is an adult, and the others are children who are 1.5 years old. And on the right side, as you can see, we initiate the surgery without an access sheet. However, the pressure has led us some complications, and to overcome these complications, we introduce a ureteral access sheet, and at the end, everything seems perfect. However, we should not. We should be careful about about introducing the ureteral access sheet. We should negotiate in care, and we should negotiate with the ureter so that no force will be there unless we put a force. The ureter has several severe complications like perforation and avulsion. Avulsion is another severe complication that we can face with, and this actually happens very rare, and it is actually also underreported. It happens due to a basket usage, or sometimes the tip of the scope can get stuck in the UPG, and when you pull it down, you can again lost in an avulsion. Concerning the postoperative early complications, we also again have minor and major complications. The most common one is fever. which can accompany infection. And when we can't realize and when we can't treat the infection in a certain time, it can lead to septicemia, which is the major complication. And the hematuria, if it happens less than 6 hours, it is transient hematuria, and it is a minor complication. However, if it exceeds 2 days, then we might need some other interventions such as angiographic treatments. So it is a major complication. And with this hematuria, clot retention and blood transfusion might be needed. And we can also have abscess and hematoma formation around the kidney. And that also is another severe complication. Most of these complications are less in grade. They are either grade 1 or 2 in Clemens scale, which is the scale that we use for postoperative complications. And the majority of them happen with positive urine culture and long operation time and high irrigation fluid rate. So the best way to overcome them is to use an access sheet. And this study, again, from the CRIRS data, has shown us that the ureteral access sheet usage can actually not lead us to too much complications as some propose. Another complication can be due to high grade. Another complication can also happen due to large stone burden. Any stone larger than 2 centimeters can have larger number of fever rate, and they also end up with longer operation time. So the risk factors for fever and infection is high intrarenal pressure, high irrigation rate, and long operation time, which we can actually control. Hematoma and extravasation are also major problems. They actually happen in patients with urinary tract infections in children and merely in cystine stones. If they are infected, we have to drain them. If they are sterile, we can observe them. 1/3 to 2/3 of the infected hematoma can lead to nephrectomy. So we should have to be careful about them. This is the patient that I operate 2 months later. He had been admitted to our hospital due to fever. As you can see, this patient had an extravasation at the time of operation, but in the postoperative follow-up, he didn't really have a major problem. However, as you can see here, he had a huge hematoma. So we had to place a drainage and we had to treat that patient with antibiotic treatments. So the ureteral obstruction can happen due to edema, clots, and due to the stones. And proper ureteral access sheet is the best way to overcome them. And ureteral stenting is another way to overcome them. In the old series, reflux has also been told. However, small caliber devices and no dilatation techniques had helped us in decreasing them. Deep vein thrombosis and nerve damage can also happen, but these can be overcome with proper positioning and cushioning. Rare complications are actually being reported like this one, where a stent has migrated outside the kidney and fistulas and necrosis can also happen in patients with radiation treatment and partial perforation and this devascularization. Last but not least, we can observe mortality. So urosepsis and hemorrhagic complications are the main reasons of death after a flexible ureteroscope treatment. To overcome these problems, we have to have patients with a sterile urine. We have to use ureteral access sheet in the ones which we can. We have to be careful about venous flow, and we have to have an operation time less than 2 hours for adults and 1 hour for children. And we also have to be careful in the post-operative phase. This is actually these are the last slides that I would like to share with you. The three important post-operative late complications that we can face are strictures, stenosis, and reflux. They happen after a month. That's why we have to be careful about them, and we have to ask every patient to visit us and to obtain an imaging at the end of first month. Instrumentation, impacted stones, ureteral perforation, mucosal lesions, and ischemia are the main etiological factors in stenosis. And reflux can happen, but nowadays it is really low because our instruments are small. And
each person question.
Stricture can also happen. We don't know the actual rate, but we can treat them if they are less than 1 centimeter with an endoscopical fashion. However, dense strictures and stone strictures which are larger than 1 centimeter need to be treated with an open or laparoscopic intervention, and we have to do reconstructive surgeries for them. Thank you for your attention.
Thank you very much.
Much time. I won't go about them. These. Okay.
Thank you very much, Iloren. Now, Anil.
Yes.
I'm sharing the screen. Yeah. Can you close the screen, Iloren?
Yes, I will.
Yeah.
I will.
Yeah. Thank you. Now, all of the speakers, please stay back. We have questions. Anil and myself will ask the questions to the common questions asked by the after the sterilization talk. Definitely, this talk should not be missed because it is less spoken about and very less people talk about. Now, I share the screen for the introduction of Dr. Manas. Anil.
Next presenter is Dr. Manas Babu. He's a consultant urologist in Preeti Urology and Kidney Hospital, Hyderabad. He's working with Dr. Chandramohan. He has more than 10 presentations in national and zonal state conferences, and he was awarded a gold medal for outstanding performance in his post-graduation in South Zone Urological Association in 2017. Dr. Manas, please.
Manas, you can share the screen. And the audience can stay back for the question answers where you'll get practical answers from the eminent speakers. Even Dr. Vijay will contribute for the discussion at the end.
Yes, sir. Yeah.
Yeah.
Can you see my screen? Can you see my screen, sir?
Yes, sir.
Yeah. Thanks, Anil sir, for a wonderful introduction. First of all, I'd like to thank my guru, Dr. Chandramohan sir, and Anil sir for giving this opportunity. Till now, you have all witnessed in the last couple of hours, you have all witnessed about the wonderful craftsmanship of various aspects of the RIRS by our eminent panelists. My job now is only to brief you all about only the practical aspects of the reprocessing and the sterilization of a flexible scope. RIRS is being used more frequently for the renal stones over the past decade. Sepsis is a major concern. Unfortunately, antibiotics are not the answer always. According to Spalding's classification, all our flexible scopes have been classified as semi-critical devices, which require either the sterilization or the high-level disinfection. As you all know, sterilization is a destruction of all the microorganisms, including the spores, whereas disinfection destroys most pathogenic microbes, but not all. For sterilization of the flexible scopes, low temperature sterilization is best at present for the flexible scopes. Is sterilization necessary always, or is possible to do the sterilization after every case? No. Are there any alternatives? Yes, there is one alternative called high-level disinfection. What is this high-level disinfection? Nothing but a chemical disinfection. Though it's a disinfection, given the adequate time, these chemicals can act as a sterilization also. What are the recommended chemicals for the high-level disinfection? Commonly are the aldehyde groups, mainly glutaraldehyde, and other chemicals like peracetic acid, sodium hypochlorite are also used. Manual cleaning is more important before any disinfection using. Our flexible ureteroscopes working channels are the narrowest channels when compared to all other flexible scopes like gastroscopes and endoscopes. And the cleaning of these narrowest channels is of paramount importance to avoid the sepsis. And reprocessing of the flexible scopes have been defined into 8 different categories. And I will show you the brief videos about each step. First is the pre-cleaning. This begins as soon as the scope comes out of the patient body. Main aim is to make the scope less contaminated for the further handling. Commonly used is either water or the enzymatic solutions can be used to clean the scopes. After the cleaning of the scope, main aim is to check whether the scope is leak-proof or not. These are the 2 scenarios in which first one is a leak test positive, where the scope is not able to maintain the pressures. Whereas in the second scenario, the scope is able to maintain the pressure, means the scope is good. Where in the first case, the scope has a leakage in the flexible channel. Confirm this when we are water, we can see the air bubble damage because of the laser fiber induced damage. Once the scope is leak test positive, then scope goes directly for manufacture for the repair. When the scope test is negative, then we take the scope for further cleaning. In this cleaning, mainly the scope is cleaned both interior and exterior with the enzymatic solutions, whether using a 10 ml or 20 ml syringe, thoroughly flushed so that all the debris, blood inside the channels should be washed out. During the cleaning, there are also manufacturers provide the various shapes and sizes of brushes to clean all the valves and the channels. And this is also important to clean all those channels before going for the disinfection. After the cleaning, all the residual debris should be washed out in the process called rinsing. In this rinsing, we commonly use deiodized water, distilled water, or the tap waters. And the special care should be taken to clean the eyepiece and the distal lens. Commonly, we use the 70% isopropyl alcohol, either the disposable swabs or the wipes are available. And the disinfection, this is the main heart of the high-level disinfection program. Whatever the disinfectant you use, most important thing is you have to make sure that your scope is fully immersed inside the scope for the adequate prescribed contact time. Once the scope is being immersed in the disinfectant for the adequate time, the scope is rinsed of all the chemicals, where commonly only the deionized water or the distilled water only should be used. Then comes the drying of the scope. The main aim of this drying of the scope is to make sure that all the water content or the chemicals inside the channels should be dried. This can be helped by using the special type of air guns, and also using the 5 to 10 ml of 70% isopropyl alcohol can be pushed into the channels so that the drying process can be improved. After the drying, the scopes should be placed in the manufacturer provided packages, or it can be hanged safely in the containers so that the drying process is improved. Since the manual cleaning has the human errors, to abandon those human errors, various companies have come up with automated endoscope reprocessors. These are nothing like our washing machines or the dishwashers. Just we have to place these used scopes after pre-cleaning into these containers after the pre-required connections. With the touch of a button, these automated processors cleans the scopes, makes them easy and ready for the next cases. And sterilization, the most common is the low temperature sterilization techniques. There are various types of techniques are available. The first and foremost introduced was the ethylene oxide, ETO. Then came the gas plasma vaporized hydrogen peroxide sterilization system, mainly called as STERAD. Vaporized hydrogen peroxide system, STERIS V Pro Max. And the latest new kid on the block is the vaporized hydrogen peroxide with the ozone, manufactured as Sterizone. What's the main common difference between the ethylene oxide and the hydrogen peroxide? Ethylene oxide is commonly toxic and it is a carcinogenic, and the cycle time it takes about 8 to 10 hours. And the ethylene oxide is also inflammable and is not environment friendly. Whereas hydrogen peroxide systems are non-toxic and the cycle time is very less. Within 1 hour, the scopes will be ready for reuse, and the environmental friendly, simple to operate, and compatible with most of the medical devices and the materials. In our institute, we use this STERAD 100S system. Since last 1 year, we have been using. After you started using this STERAD system, we could see that gradual decrease in our infection rates. To conclude, flexible ureteroscopes are delicate and costly. Sepsis is a major complication of RIRS. Proper handling not only prevents the cost, but also avoids injury to the patient. Manual cleaning is most essential component. Liquid disinfection is commonly used in India. Expiry and efficacy of all these liquids should be monitored on daily basis. STERAD-like systems are highly efficient and suitable for the institutions. Thank you.
Thank you, Manas. I wanted all the speakers to be on the line. We will take only 10 to 15 minutes. There are some questions we will quickly answer depending on the talk. Anil,
yes,
yourself and myself will be asking question pertaining. Now let us start first with Tanuj Pal Bhatia. I will ask first question.
Yes.
Tanuj, honestly, everybody asks which scope I have to buy in India. Now I am giving 3 options, A, B, C.
Yes, sir.
XX2, P7, Fusen or Indovasive. If you want to buy only one scope, no conflicts of interest, only your personal opinion. There is nothing wrong. You have all the scopes with you, but you give your opinion. Because many ask this, we don't answer. Only one, ABC, it's like MCQ question, neat.
Sir, FlexX2S is my favorite scope.
Okay. Anil, you want to ask some question related to flexible ureteroscopes and accessories?
There is a question by Dr. Pramod for Dr. Tanuj. Is there any differences or difference in exit point of laser fiber in different scopes? And does it have any significance?
Yes, there is a difference, as we know that in most of our P7 and FlexX2S, the laser comes out usually around 10 or 11 o'clock position. In V3, it comes out at 9 o'clock position, and FlexX2S comes out at 1 o'clock position. So sometimes it helps, like Dr. Dr. Gandharv sir showed that case where there was a stone in the lower calyx and it was in an anomalous kidney. And the basket coming out from that 1 o'clock position, it helps to go there and hold the stone or break it right there in difficult position. So some special cases, it does help to have a specific scope for specific location.
Thank you, Dr. Tanuj. And my question to Dr. Tanuj is, which
Dr. Manas and Dr. Vijay, please open your video so that we can have a screenshot. Yeah, hi Vijay.
Hello. Hi.
Hi. So you are not introduced. I will introduce with my share screen. Just give me a second time. Vijay Kohli is originally from Indian, but he settled in USA. He is chief of urology at Summerlin Hospital. He has special interest in minimally invasive procedures like laparoscopy, stone disease of in-office lithotripsies, and urological malignancies. Thank you, Vijay, joining us. Now we will ask the question to the second speaker, Professor Lee Jun.
Dr. Chandramohan, I have a question to Dr. Tanuj.
Yeah. Sorry, Anil.
Yes.
Yes, sir.
Tanuj, if you have to choose a basket
Yes.
What are the specifications that you look for when choosing a basket? What else do you see when you buy a basket?
When you buy a basket, see, like Dr. Michele actually mentioned that nowadays we should prefer a basket which is thinner, so that in case we get stuck, we should be able to pass a laser fiber by the side of it and break it or break the stone so that we can take it out. And it has to be a tipless nitinol basket for sure. Otherwise, I have special choices for special purposes. For example, if I have to take out multiple stones, then I like to use the N-compass basket. If I have to take out one single fragment or single small stone, I prefer N-gauge, and to relocate, I prefer an N-circle type of basket. So one should have 3 or 4 types of baskets ready, and whichever can be opened as required. They can be reused even though it is off-label.
I want to ask the same question to Michael Talso, who presented. In your office, what is the common basket you use? For example, I use N-circle most commonly. Michael, is he here?
He's not.
Esteban, on behalf of him, you know him, your close friend?
Well, I don't know what he's using. I'm always using 2.2 French circle baskets.
Vijay?
I use the zero tip basket from, it just seems to have less incidence of complications for me.
You use N-circle or which one?
N-circle, sir. Yes.
Yeah, zero tip N-circle. You want to use.
Correct.
Katar, sir, what is your favorite basket?
I use 1.9 French basket, and I have all varieties of basket with me. So depending as
what is the commonly used?
Yeah. So that is what I'm saying. That N-circle is a preference, but sometimes I use even a grass pit also.
No,
it's
sir.
It's a
one commonly
basket.
used.
Yeah, N-circle. Yeah.
N-circle. Anil, you want to ask anything more?
Thank you, Chandramohan. We can move on to second presentation.
Second presenter is single-use digital, but he is also experienced in pediatric. He has the paper who has less than 2 years children, total 17 cases he attempted, and in which 12 he succeeded. I want to ask a question. When you fail in RIRS in children, what is the most common cause of failure of RIRS in children less than 2 years? Professor Lee Jun.
Hello, it's me.
Yeah. What is the common cause of failure RIRS in less than 2 years?
Actually, in my center, we don't have the RIRS failure in children, because before operation we will choose carefully, we will examination carefully, and now from last year, actually most of my pediatric cases were if the kidney stone more than 1.5 centimeters, I will choose PCL instead of RIRS. Because now we have the 4.8 microperk system, so we can use micro PCL easy and I think safe.
So you select the case before only. You select the case before only, depending on the size. You will not attempt in large stones.
Yes, if for large stone, we will choose. If a stone larger than 1.5 centimeter, not quite large actually, for adults, we will choose PCL instead. So now we don't have much failure RIRS, but actually before 4 to 5 years ago, we do have failure RIRS. If failure RIRS, we will choose PCL.
Do you use stent in all the children? No.
Use what?
Stent in all the children?
So you mean per stent?
Yeah.
Per dilation? Yeah. If for RIRS, if I choose RIRS, 100% per stent.
Okay, that's a good message to all the audience. And anybody wants to share? Anil, you want to say anything about this? Better to stent in children?
Definitely, definitely. I think I have done very few cases in children, but I routinely stent, pre-stent, and even after the procedure, I stent.
Yeah, thank you. Next, I want to ask you one more question. Single use, you are talking about pus and professor. How do you choose? Is the patient chooses or you choose?
You mean?
Single use. How do you choose in your theater? You have FlexX2, you have your local scope, you have a disposable scope Pusen. How will you choose? Is it because of the payment is more or insurance or case selection? How do you
No, in my center, normally we choose single-use flexible scope. So before Pusen, you know, we choose poly before, 5-6 years before. But now we have Pusen. So normally we choose single-use digital scopes. We choose, actually, we not quite often choose reusable scope because very expensive and no charge. In China, no charge for reusable scope. So if we perform flexible scope operation, I will choose the single-use scope for the patient. And actually insurance covers the single-use scope in China. So
I want to know from European countries whether a disposable scope is covered in insurance or not. In India, it is not. Whatever you do, they will give fixed amount of money. I want to know from European speakers.
Yeah, in Spain and I know also in Italy it's covered.
Yeah, it is.
Oh.
Vijay, your opinion in USA?
Yes, sir.
You use which disposable scope?
Yes, I use a disposable ureteroscope. I began using disposable cystoscopes in the office 5 years ago, and I began using the Boston Scientific disposable ureteroscope. Now I exclusively use the Poussin scope because of the ease of use and also the cost. There's no distinction for us for payments, whether it's reusable or disposable. So we get a flat fee. We just found that it's much more safer, of course, and now with everything else, with these viruses and everything, it's much easier too, because we always have a scope ready and available to use. So that's why we found it much easier.
You use only one time? Only one time?
Yes, sir.
Yeah.
Yes, sir.
In India, we use, I mean, more patients after sterilization. I have steroid, I have both chemical. When I used in chemical, it got damaged within 2 cases. This is my experience I am sharing for the audience. Tanidhir and Anil, anything to say on that? Nothing. Tanuj, have you used disposable second time, third time to other patient?
Yes, sir. Yes, sir. I used 8 cases in one day.
8 cases in one day?
8 cases in one day. Thulium fiber laser and endovasive scope.
What is the sepsis rate on that day?
No, sir. All patients fine. All discharged on same day. It was in, one of my friends has made a daycare RIRS center in one of the towns.
I remember an abstract presented. at WCE. It was 2016, I think, and it was a comparison. I think it was from an Indian center between. They just evaluated reusing the single-use scope, and complications were the same.
Okay, so one tough question. Laser fiber reusable is very common. It cannot be disposable in India. How do we sterilize? Now we are keeping in sterile. I am not getting it damaged. Anybody what is the official recommendation? What is the experience? Anybody wants to comment? Anybody can comment. Laser fiber sterilization. I am using sterile, no problem.
I think Chandramohan, in my hospital, we used to do a sterile sterilization for the laser fiber. Now, if you want to do the sterile sterilization for the laser fiber, there is a recommendation that each laser fiber one should put. Supposing there are some funny laser fiber, if you put it in the stirred, it certainly reduces the life of a laser fiber. That is like when you use a stirred sterilization for your scopes also. In my hospital, we do it regularly. But it is theoretically, it is said that it reduces the life of the scope. Similarly, for the laser fiber also, the story is the same. But you can do even ETO sterilization. If you have got a possibility to do ETO sterilization, I think that is good. Some people clean it with the whatever side X and whatever, but I don't believe in that. So either you do a stirred sterilization or you do a ETO sterilization. That's a good method for a reusable laser fiber.
Yeah, not many papers are available on this, especially laser fiber. When we ask Oliver Traxler, he says only one question: disposable. He says like that. It is very practically not possible. Now we'll go to the Dr. Michael Talso, baskets and basketing. I have an impression that if you do complete powder, the role of baskets in theater is very, very less, except for taking a piece for the analysis, which we don't do in adults. By look wise, we think that this is a stone. So on relocation also with a smaller laser fiber is not required routinely. So Michael Talso, please tell me, in your theater, do you keep basket regularly with you? Which basket? How often you use?
Okay, so totally agree with you. Nowadays is not mandatory to open a basket. I never open instrumentation before using it. So I have everything available in my theater, and then I ask nurse to open or not the basket. So if it's first time for a patient to get treated, I need a sample of the stone always. And I need a sample even to get money from my hospital. Otherwise, if you don't have any stone analysis after retrograde intraocular surgery, then you don't get reimbursement. So usually I get one sample with a basket, but I do not do basketing. I do dusting most of the time. There is a paper from Manoj Monga that says that outcomes in between basketing and dusting is almost superimposable. It's almost the same, because doing dusting, then you last a little bit more time, but then you don't have to do in and out. Plus, if you're not using an access sheet, sometimes doing basketing is not really nice because you have to pass through the ureter many times, and this is not really nice sometimes, especially if ureter is narrow, if the UPJ is inflamed, and so on. So totally agree with you. I do not use a basket routinely, especially if it's like a stone former. So I already have the stone sample, and I don't need to do another stone samples. If like the vision, for example, if you know there is a calcium oxalate monohydrate, and in the second surgery I see the aspect of the stone which seemed different from the previous surgery, then I do a sample again. Otherwise, I do not get another stone sample. Okay. For the question, what kind of basket do you use? I almost always use the normal 4-wire basket, the Dormia basket, smaller than
N-circle type.
N-circle. There is the 0 type, the no type. It depends on the brand. So it depends if you go Color Plus, if you go Boston Scientific, if you go Cook. That doesn't matter. The thing that is important is that it has to be smaller than 2 Frenches, as I told you. And for me, actually, in my own practice, and the 4-wire, it's good. Then, of course, it's really fancy to have Engage, to have this kind of beautiful basket from Cook, for example, that you can use in order to get some small pieces, but it is not normal routine.
Okay. Anything from Vijay?
Chandra Mohan.
1 second, sir. Vijay, you want to comment on basket? No.
Yeah.
Perfect.
No, I don't use a lot of basket because I believe in dusting as well.
Okay. Kandarp, sir. Kandarp, sir.
Yeah, so Chandraman, I just wanted to add one comment because you asked that whether you want to dust or basket. Yeah. So one very practical tip which I can give, that it all depends on what is the size of the stone and where is the patient, from where the patient has come. If the stone is not a very large stone, it's a small or medium sized stone, sometimes I want to make a complete clearance. And as you know that our theory is to initially dust the stone, but at the later on view, it is impossible sometimes to get a complete fragmentation, especially in a complete dusting, especially in a case of calcium oxalate monohydrate stone. So sometimes what I do is that I dust the stone, and then because most of patients I use ureteral access sheet, so I use a basket and grab it and try to give a complete clearance. So when the patient goes to some other doctor, maybe after 15 days or
Okay,
1
sir.
month,
That
he
is
has got...
understood. What I wanted to ask, 5 years back, there used to be a surgeon in Panipat who used to take out 100 pieces and show complete clearance in the kidney, but you have to take out 100 times flexible scope. Nowadays, I am not seeing any of these seniors doing that.
Okay,
Do you all agree?
Perfect.
So pop dusting, once it has come, especially with high watt laser, high frequency lasers like TFL, that point will not arise. With that, Anil, you want any question?
I'm fine, thank you.
Yeah. Next is intrarenal pressure. I want to ask you clearly. I wanted to do a study on that since long time. You just elaborate what you have done with that epidural catheter. Where is the sensor available? How costly it is?
So it is actually a normal epidural catheter, which is 2.9 French in diameter.
How will you insert?
So it is a kink resistant epidural catheter, which is normally used by our anesthetist friend. And I insert it with a semi-rigid guide, semi-rigid ureteroscope like a guide wire under visual guidance, and I place it in the renal pelvis or in one of the calyces. So then I take out my semi-rigid, then I put a guide wire, cystoscopy guided, then I put a access seat. By putting an access seat, that epidural catheter remains outside the access seat.
Yeah, understood.
So then I connect the epidural catheter with a arterial line catheter.
Okay.
Arterial line catheter. Or
it will fit exactly into that?
The anesthesia machine.
Okay.
It's like measuring a central venous pressure or arterial line.
What is the size of the epidural catheter?
2.9 FR.
It is available freely?
Yeah, it is available. It is available. But
Esteban, you wanted to comment on that? Probably worked with Olivier, and how will you measure the intrarenal pressure for studies?
Well, it's very difficult, but the only way that I've done it or that I've seen done it is with the as you measure intravesical pressure with the urodynamic studies, but it's just a sensor that you can just put up the ureter, a long sensor, as well as the coronary pressure measurement and measure instruments.
Yeah, Professor Lee, lot of papers have come, but how they measure in China? How do they measure intrarenal? Do you put from PCN tract or from below? Because ideal measurement should be from PCN, because it will not interfere your movements. It will not interfere with access sheath insertion. If anybody can do supine PCNL well, and with a small tract, you put it and take out the access sheath, is it correct?
Sorry?
Intrarenal pressure measurement, how? Do you have any experience?
For me, if for RIRS, we can't measure the pressure intracollection system. So normally I will use the human pump. Like for doctors, push the saline for me. If I can see clear, stop. If can't, he will use a syringe.
No, actually I'm asking, do you have any idea how to measure intrarenal pressure? Any study you are related how to measure intrarenal pressure? No.
No.
Michael,
we don't have the equipment for measure.
Okay. Michael,
can I add something?
Anil.
The measurement of intrarenal pressure is very difficult, as Esteban has told. The vascular transducer is the best one, but they are very, very expensive. That's the reason why we don't have good studies of measurement of intrarenal pressure in patients yet, because there are lots of studies going on in another aspects, but intrarenal pressure, we had a discussion with Professor Traxler when he was in Kathmandu this March, and he said that maybe in future there will be scopes with a sensor at the tip for the pressure measurement, or maybe there will be an access with the sensor, you know. So, but to date, we don't have a proper device to measure the IRP.
Thank you. Michael?
Exactly. I was commenting on this exactly. If there is someone from some companies that are listening to us, especially companies producing single-use scope, they should think about a sensor to place at the tip of the scope in order to measure the pressure over there. So I will be able to adjust my pressure like live during live surgery.
That is a very, very important point.
I think
Chandramohan,
Boston Scientific, the next generation LithoView, I think probably will have a sensor at the tip. They are working on it. So there is a sensor at the tip of the scope with the LithoView, and also it's important to measure even the temperature, because there is a lot of discussion going on about the temperature rise during the laser lithotripsy. So there could be a scope in future where we have got two facilities. One, it will measure the intrarenal pressure, and second is the temperature within the system, so that all the discussion regarding the thulium fiber raises lot of temperature rise, or holmium can lead to a temperature rise. I think that will be settled in future.
And we will be very surprised, because I don't think we know what we're doing. I don't think we really know which pressure are what kind of pressure we are using, or with what temperature we're giving to
I
the
think
kid.
lots of secrets will be revealed, right, Esther?
Regarding the laser settings, I want to ask Swami, with his experience of doing both thulium as well as this thing. Everybody should contribute. This is important point. Still nearly 150 audience are watching. So when you do a large stone faster in the pelvis, when you wanted to do a larger stone in the pelvis, what is the laser setting you keep?
So first of all, we should use to dust the stone as much as possible by using the holmium laser with the highest energy and highest frequency. Because of the volume of the stone, it will not allow it to fragment very early. So we'll get some time to dust the stone as much as possible. So once the stone size reduces, then you can reduce your energy and frequency accordingly. And once the stone has formed into multiple fragments, then either you can use the pop dusting with the holmium or with the thulium and complete the stone there.
Do you like to push the stone into calyx when it has become small to do pop dusting? Or can you do pop dusting in pelvis? Because pop dusting in pelvis is difficult. The fragments spread. So do you like to push?
Yes, sir, 100%. Once the stone size is reduced, you have to get it into a calyx to further fragment that stone. So if it is in the calyx, then only pop dusting will be better.
Quick opinion, raise the hand and answer. I want to know quickly answer for this, whoever has done publish or anything like that. First, I will ask Kandarp sir. Esteban, you raised your hand.
Yeah.
Yeah, large stone means 2 centimeters in the pelvis. Everything you have in front of you. How do you manage to go faster?
Well, first of all, it depends on the type of stone that you're treating. If it's a soft stone, you can go very fast with a very low energy, 0.3 joule, 20 hertz. But I really recommend not increasing the frequency too much, because then you'll have a lot of dust and you'll have to stop your procedure from time to time to clear the view. So sometimes it's better not to go very high in order to be very consistent. You know what I mean? And
Yes.
So watch it, because well, I think you can be more efficient if you don't go very fast, because you will have a continuous treatment.
With high frequency, and Esteban probably remember this, we made many studies in vitro when we were in Paris, and with high frequency, you have heating, which is horrible. which is really, really, really horrible. When you start to have like more than 30 hertz, then it's really boiling water. Water around the laser fiber tip, it's really, really warm, really, really hot. So probably you have the albuminization of the mucosa, and then can end in urethral stenosis, and we really don't know.
So nobody is recommending high frequency in doing large stone, which is of less use. In fact, Oliver Traxler.
Sorry, sir. What do you mean with high frequency? This is the point.
More than 30 hertz.
I recommend high frequency.
Is it?
Yeah. Yeah. Normally, if for me, if for large stone, of course, much fragile stone, I will use 30 to 40 hertz, but I will use 0.8 or 0.6 joules for dusting.
What is the advantage? Is it faster dusting or
faster dusting? Faster
dusting. I feel in the beginning a little high energy like 0.81 and medium frequency like 2015 makes entire procedure uniform and you need not stop. That saves the time, is my opinion. Majority of the person's opinion. But other version is some people use high frequency. Now let us go to the next question, fluoroless RIRS. I want to ask Anil, sorry. Anil,
yes.
Sorry.
Actually, we were observing a small, differences in high power and low power laser for medium sized stone, less than 2 centimeter in our department. And what we observed is there is not much difference, not much difference in terms of lasing time, in terms of operation duration, and in terms of stone clearance. So when the stone is, larger than 2 centimeter, then maybe it is required. It also has to be proven, but for moderate size stone, if you have a laser machine with 30 watt and like a conventional laser machine, I think that's fair enough, and
that's
you can.
Fine. That's fine. 30 watts is a fairly good mission to do up to 2 centimeter.
The only difference that we found in that comparison is the total energy used is much higher with high frequency, higher power laser. Rest is same.
Okay. Now coming to the fluoroless RIRS, Esteban, I want to ask you, do you wear thyroid protection regularly or not in urology OT?
And let me add. And what about goggles? Goggles.
I use goggles and neck protection. Always. I use it. I use always.
Any hand protection?
I use hand protection. I use gloves always.
There's
evidence.
How many of you are using the neck protection during the endourology procedures?
I use.
I don't use. Professor Lee Jun?
I use.
Vijay, I think you will be using? No?
Vijay, no, sir.
Thyroid protection, neck? No.
No, I use very little fluoroscopy.
Even if you use 0.1 second, will you wear the thyroid shield or not?
No, I just step away.
That's the trick. So number of surgeries, if you do more, it adds the frequency, 0.1 into 100,000 cases. It may be cumulative effect on your body. I read recently that you have to wear thyroid because thyroid carcinoma is also very, very common. Kandarp sir, you want to say something?
No, I strongly believe that I think one should use at least thyroid. We are using minimum radiation. But I think thyroid shield is good. I'm not using hand gloves because I think that amount of radiation which my hand gets on RIRS is, I think, probably comparatively almost negligible because we are minimally using the radiation and hand is quite away from the patient, from that imaging tube. But I think thyroid shield, yes, I'm wearing it. Yes.
I totally agree with the gloves, but the problem is that what happens if you have a very difficult case and you have to do a lot of fluoroscopy and you have your hand on the field, for example, or very near the field. You cannot predict that. You have to be prepared. That's why I use it.
So
sometimes, Esteban, are you talking about PCNL or RIRS?
Both.
RIRS, both. Anil,
Yes.
sometimes unexpectedly we go long surgery. That
Yes.
time we realize that we have not worn anything. That is the time we get burned. We don't wear again. Sometimes unexpectedly you get delayed, and you in the RGP itself, 15 minutes you will spend continuously pressing. Phenomenal amount of radiation comes. So the message is probably that we have to wear continuously. And now I want to ask all of you, how many of you use 9.5 French access sheath in the beginning versus 12? Just raise the hand for 9.5 for a fresh case, non-stented. Smaller size, how many you uses?
9.5.
Depends on the ureter, sir,
3.
but we do use.
Only 3 people in 9.5. I also use only 9.5.
Rest
Not
only.
Rest of all are using in primary cases 12/14.
No, I use 10, 12. I 10, 12.
10, 12.
That is my preference.
Oh, 10, 12. Yeah.
10, 12, yes.
Yeah,
Because
10, 12 can admit all scopes.
it's very versatile.
Exactly.
It can
It's
fix
the
into all
universal
scopes.
one.
So I
Michael,
use 10, 12.
you want to comment, Michael? Dr. Michael also?
Yep, I use 10, 12 as well. So I spare one guide wire, but I'm not using in all cases the access sheet right now.
Okay, that's fine. For all the audience, this is commonly asked question. Yeah, Tanidir?
Yeah, I prefer to use a larger sheet, but initially I always do a semi-rigid ureteroscopy and check the lumen. If the size is compatible and if it is easy, I try to access a larger one to have a less intrarenal pressure. However, if I can't proceed that, then I get to little ones.
Okay, Esteban, you want to say something? No. So now for all the participant who are more than 120 now on the board, they ask what size access sheet. Now 10/12 is commonly used by many of the seniors to have both scopes. You can switch over to fiber optic, you can switch over to digital, depending on the case interest as well as your vision. So that is an important point. Thank you very much. Now complex situation RIRS. Quickly I want to ask Anil first. Anil, diverticulum stone, if it is more than 1 centimeter, first do you try once RIRS or go to PCNL? What keeps in your mind?
I try RIRS always.
With IVP or without IVP?
With IVP, of course.
Whenever you suspect diverticular stone, you have done CT, will you go back to IVP or don't RGP?
If contrast study has not been done, I mean IVP has not been done, then I'll do on table RGP. But I'll always go for RIRS when there is a not very big stone with calyceal diverticulum, because in calyceal
size, what is that big? What is that
calyceal diverticula, usually stones are not very big. Usually, majority of calyceal diverticular stones are not big. So I usually prefer going RIRS. And if I have to plan, then I usually plan CT IVU.
What makes you to stop the RIRS? What intuition? It says that it cannot be done with RIRS.
Yes. So I have faced it a couple of times. I went with my scope inside. I checked all the calyces. I did a blue spritz test also. But sometimes you won't be able to find the opening. You won't be, and cutting blindly is very dangerous. So I have to convert it into a mini PCNL a couple of times.
Yeah. Professor Lee, you are laughing with background lights off. You want to comment anything? Yeah, anybody a comment on the, Kandarp sir, you are experienced. When do you feel that you cannot do diverticular stone? When you switch over to PCNL?
My first preference always for the stone less than 2 centimeter in any renal stone would be, I'm tempted to do RIRS.
That's okay.
So similarly for the the calyceal diverticular stone also, I will attempt to do RIRS first. But I have, in my experience, I have observed that when it is in the lower calyx, the caliceal diverticular lower stones are very, very difficult to tackle and put a cut. So
Yeah.
I think we should be prepared mentally to convert it into mini PCNL. For the upper calyx and the middle calyx, performing RIRS in a caliceal diverticulum is not difficult. Only problem is that once in a while you can have a bleeding.
I want to ask a question.
But Chandramohan, can I just before you just leave me, I just want to make one announcement for those who are actually associated with us right now at this moment, that next Friday we are going to have similar webinar, but it will be a pointed question on RIRS involving very, very eminent international faculty. It is on a Friday between 6 to 7 this time India. So I'll be circulating the flyer very soon. I think maybe on Monday Tanuj will do that job for me. And Chandramohan, you are aware of this program. And right now I've got a confirmation from Cesare Scofone from Italy. He will be talking on ECRI. And Dr. Saeed bin Hamari is also confirmed. I have communicated with Dr. Khurshid Ghani, but I think it is not convenient to him on Friday, is convenient on Saturday. But Saturday you are conducting a program, so I have preponed it to now Friday in the evening. So date would be.
So definitely I will communicate.
So all of you
participant, all the speakers I communicate to send the flyer.
Yes, certainly I will do that. Yes.
Thank you.
You were asking.
And Michael, I want to ask even Vijay, if the CT shows the stone in the anterior part or posterior part in diverticulum, does it have any meaning on the strain of the scope? For example, half of the axial cut, if the stone is anterior or posterior, does it have anything in your mind before you take the case in?
Well, I always place my patients in a supine modified position in case I cannot reach it with my scope. But in terms of doing it retrogradely, I think it's the same in my opinion.
Okay.
Only it will be the problem will be when converging, but that's it.
Yeah.
Sometimes there is something really spoiled, but sometimes the exit of the laser fiber on your scope can help you in treating a left stone instead of a right stone, depending if it's coming out at 9 o'clock or 3 o'clock.
Yeah. So I want to add a little bit with my experience. For last 10 years, I was doing prone PCNL. Last 8 months, because I started doing more large stones, sometimes I fail. I am switched over to the supine PCNL with ECIRS. It really made the difference. And patients who are poor, large stone burden, my scope is not reaching very easily to the stone. I quickly changing my decision to go to supine PCNL and clearing it. This I am feeling very comfortable now. That pressure of doing 2-3 times RIRS is reduced on me. If the patient accepts that, okay, you do whatever the best for me, I am switching over to the supine PCNL.
Yeah.
Thank you for that. The next complications of RIRS, I want to ask
for you, Dr. Chandramon.
Yeah.
A question for you from audience. How do you decide when to do RIRS or ESWL or mini PCNL in children? How do you decide?
I don't have ESWL mission from beginning. For children separate, I asked already Professor Lee Jun. He said that separate head is required. It is very costly. ESWL is technician dependent, I feel. So already in children, you need anesthesia. So I don't do it. Number 2, PCNL for more than 2 centimeters without any doubt. Without any doubt, more than 2 centimeter or large volume, 2 by 2 by 2. Then I will not do RIRS. Pelvic stone less than 2 centimeters, I put stent. RGP, if the RGP is very clear, pelvic stone I always do. For inferior calyceal stone more than 1.5 centimeter, I am trying to avoid. So my answer is over.
And
all cases less than 1.5 centimeter, definitely I will attempt RIRS.
So what about irrigation in children for RIRS? Another question.
till recently, after listening to you and other persons recently in Trichy conference, I have seen the Vikram who is doing with Lasix and normal irrigation. I am also feeling that normal irrigation can be tried. Till now, I am using only 20 ml syringe very slowly. But I feel after listening your talk and recent experiences, normal irrigation, I want to listen all of you. How many are using normal irrigation? Can you raise the hands? Normal irrigation. Oh, so message to the participant that please try normal irrigation. Even if your vision is little less, don't worry and finish. Probably complications are less. Do you agree, Anil?
Yeah, normal irrigations are good, but it's not always adequate. And intermittent manual pump, gentle use of intermittent manual pump is necessary.
Okay, so that's
By,
okay.
by the way, I would like to add something. For children, if you have a heart stone, which is denser than, for example, 1,500 Holtzman units, then you should also prefer percutaneous approach, because for the harder stones, the operation time will exceed 1 hour, and it is not really nice thing to do for the children.
Professor Lee Jun, you should comment on this. Professor, children,
right.
what is your upper limit time?
So the signal is not quite good, but if for children, for heart stone, is that a question?
Yes, and how much time you like to spend?
Normally, if for children, if the drainage is good, I will perform the operation maybe average time 1 hour. If more than 1 hour, I will examine the child, and if everything's good, 1 hour and 30 minutes. But normally, I will not like the operation last more than 2 hours. I think the irrigation is too dangerous for our children.
Yeah.
If we use much more saline, I will stop the operation. So now in my center, the average saline I use for RIRS is average is around 900 milliliters for one operation.
We use around 700 to 600 to 700. Tanuj, I want to ask you, even in adults, we restrain up to 1 hour only. Very rarely we stop the procedure after unless it is going to be finished in another 5 minutes. Tanuj, do you like to spend more than 1 hour in RIRS in any point of time? Unless there is a technical difficulty, that's a different issue.
No, sir. Most of the time, our choice of stones are like that we are able to finish in that much time. Yeah. And 90 minutes is generally my upper limit. I stage the procedure after 90 minutes.
I have seen Tanidir presenting 2 hours. I have done very rare 2 hours. 2 hours, what happens I have seen is the intrarenal bleeding will be more. Mucosa becomes edematous and capillary ooze will be more. Any comments on that?
I think I have mentioned in my presentation that duration of surgery, even the persistence of lower pressure, even the pressure is not very high, the duration also matters. When the duration becomes longer, there is a venous congestion of the kidney. Yeah. And it starts bleeding, and it gets, there is a certain degree of ischemia of the kidney. Yes. So duration matters.
So we will come to another 2 questions and conclude because we crossed our time way. Regarding the sterilization, I have seen that if you do more than 5 cases with 2 scopes, 5th patient or 4th patient chances of getting fever is high. This I observe in conferences. I conduct every 4th Saturday where I use 6, 7, 8 patients. That day fever is slightly more. You want to comment on Manas? First I will ask you, is the number of cases done in a single day, does it matter for sepsis or doesn't matter?
So even though if you do increased number of cases, if you do the proper disinfection, high level disinfection, give the adequate contact time for the disinfectant to sterilize, then the infection chances will be less, sir.
Vijay, Dr. Vijay?
I don't use any reusable scopes.
You don't use
So
any reusable?
No, that's why I don't have those problems.
Oh, so every case you use disposable scope and throw it away?
Yes, sir.
All cases?
All cases.
Oh, great. Any comment on the number of cases versus infection if you are using reusable? Chemical sterilization particularly, anybody wants to comment? In fact, Kandarp sir should tell because he is suitable to India, doing a lot of cases of RIRS. Unmute, sir, unmute.
You said that only the chemical sterilization, but I'm not using a chemical sterilization. I'm using steroid sterilization for all my patients. We have got about 4 scopes in my hospital, the 2 digital and 2 regular flexiscope. So, and my personal preferences now, I think probably lean towards using a digital scope because that makes my life easy and I really love it, the vision. So if possible, I use a digital scope. If not, then I use a flexible scope. But all scopes, all camera heads, all light cables, everything is steroid sterilization. Everything is steroid sterilization in my hospital. We don't have we don't use Cydex at all. Okay. So Cydex or Parasafe or whatever. So our infection rate, we have published it also, that our infection rate, and I think somebody from the audience also asked the same question, our infection rate has significantly gone down, almost matching to the international standard. So as if you are using a new scope every time. Of course, there are many factors that lead to infection, not only the sterilization, but I think the rest of the things we are careful about it. So yes. I think that will help. Yeah.
I'm asking the last question to everybody. If you have a 6.5 disposable scope at very low cost with 50 micron laser fiber, which can go to 100 watts, do you think that in future PCNL become obsolete even in stagger? Is it a possibility or no? How many of you think that this is going to happen in near future where larger stones can be dealt easily with RIRS?
This is what's coming with thulium fiber and with smaller flexible scopes. This is what we need. The problem is that we don't know what's going to happen when we leave that many dust in the kidney. We don't know what's happening when we're treating large stones. I don't think it to replace PCNL, but we'll see.
Chandramohan,
we don't know. Nobody knows.
I had my presentation in World Endourology Conference, and jokingly, in fact, that was a debate between PCNL and RIRS, and jokingly, I just put one slide that in the era of standard PCNL and RIRS, do we have a scope for?
Yes. Hello.
That if there is a very large stone, in that case, you can deal it with the standard PCNL. You don't want to leave a lot of stone inside, a lot of dust inside. But if there is a moderate size stone up to 2 centimeters, I think you can deal easily with RIRS. So it will be probably a mainstay of the treatment in future. That's what is my prediction, and everybody loved it.
Guidelines will recommend as first line of treatment?
I think so. I think so, except that maybe in future some study will come up that because of the temperature rise, there is some kind of a damage in the kidney, or that we have not observed physically. When we do a ureteroscopy after maybe 15 days or 20 days, when we go in, the kidney looks absolutely normal. There is no dust even. Yes, there is no dust even. So I'm very, very positive about RIRS, and actually probably it might be my personal bias also. And but I think that probably the time will come that RIRS will replace mini
the only place where
PCNL, not PCNL, mini PCNL. Okay.
That is the only place where ESWL is still finding a lot of places in children. I don't know. It's the choice. It's the choice up to 1.5 centimeter in any guideline. But latest articles on pediatric ESWLs are not available. Guidelines are not changing. Articles are not available. Professor Lee Jun, you should give the conclusion comment and then we will close.
You mean T-cell filter?
ESWL in children, why ESWL is still the first choice, no change in the guidelines?
Yes, still, I think ESWL, if for pediatric case, ESWL may be the first choice for stone less than 1.5
But you don't
centimeter.
do, a senior professor like you never do ESWL. Children.
Sorry?
You are not doing ESWL for children at all.
Yes, yes, because we don't have the special equipment.
That special equipment is a problem everywhere in the world. Then how can it be a treatment of choice in small children is my doubt, because I am concentrating on children now. I don't have that mission. I cannot afford. It's like robo. It's a good mission is nearly very costly. So with this, Esteban, you want to say comment? Yeah, with this we conclude the session. I have taken a picture of all of you. I will send in the group. I thank all of you, and still the more than 100 participants are there. 3 hours, and other groups also.
Esteban has already shared it on Twitter.
Yes,
Esteban has already
I will
shared it
share
on
the
Twitter.
link of your talk separately to you, and I will share the entire link also. With that, we will say bye-bye. Is it okay?
Thank you so much. Good night.
Thank you so much.
Thank you.
Anil,
Bye.
special thanks to you for introducing all the international faculty. Thank you very much.
See you all guys on Friday evening again.
Yeah.
Thank you.
One more thing is that we will try to keep the group alive so that we can add some more juniors who are interested in RIRS. If you are interested, stay in the group. We'll make it bigger. WhatsApp group.
Thank you.
Thank you very much.
Thank you, Anil. Thank you. Thank you, Chandrammohan. Thank you.
Thank you very much, everybody.
Bye.
We are leaving the meeting.
Thank you.
Stop the recording. Thank you, Tanush. Thank you, Tanidhar. Thank you, Swami. Thank you, Michael.
Thank you. Bye.
Bye.